want to start off by saying, on behalf of Dixon Center for Military and Veteran Services, we are excited about partnering with Consensus Health once again in shining a spotlight on the challenges that veterans and their families face in finding and receiving quality health care. And I'm also excited, again, I have the opportunity to moderate our first panel today, and you're seeing some of our panel members now starting to join us. And very shortly, I'll introduce them. They are a group of practitioners, thought leaders, researchers who every day are examining how to bring better care to those in marginalized communities, including our veterans. Again, I'm Colonel Sam Whitehurst. I'm the Vice President of Programs and Services at Dixon Center for Military and Veteran Services. But before I do go into introductions and allow them a chance to make their opening remarks, I would like to set the stage for today's discussion for our very first panel. And as part of this, I'm drawing upon a recent report called Stand To 2021, Advancing Veteran Employment, Education, and Health and Well-Being, that was published this past February by the George W. Bush Institute and the Institute for Veterans and Military Families at Syracuse University. After looking at that, I think I have found that some of the observations in the report really should give all of us pause, and also highlight the urgency of ensuring that veterans and their families have access to quality health care. From the report, for example, they make note that veterans who receive their health care from the VA, and as many of you know, only about half of the 19 million, almost 19 million veterans that are in our country do receive their health care from the VA. But those who do receive it from the VA, for those that live in rural communities, it can often be very challenging, very difficult, just because of the geographical distances involved. And then for those veterans who do receive their health care from private providers or from community providers, they sometimes face obstacles due to a lack of understanding of military culture and other contextual issues. Women veterans in the report that they have challenges accessing gender-specific services. And post 9/11 women veterans were significantly more likely to say that they are not prepared to successfully navigate the healthcare and benefit system. And specific to mental health, negative beliefs and stigma associated with mental health still makes veterans reluctant to seek treatment. One of the things I found, I guess, most alarming about the report is that over half of the respondents to the Stand To survey who reported a mental health problem, half of those did not seek care. And veterans, as also noted, veterans have unique healthcare needs that often require coordination of care across multiple chronic conditions. During today's discussion, what I hope is that we're going to tackle some of those issues, some of those statistics that I just went through, but we're also going to try to answer and address the following questions. How do veterans access their health care? I think there is a perception that all veterans receive their health care from the VA. And as many of you know, that's not exactly true. Again, about half of our 19 million veterans get their health care from the VA. Others seek it from private and community providers. And unfortunately, their sole source of health care is either coming from urgent care centers or emergency rooms. What are the specific challenges that veterans face in accessing quality health care? How do these challenges impact different veteran populations? Women veterans, veterans of color, rural veterans, and veterans on the edge of poverty. And are there challenges, are there lessons learned from how we approach how veterans access health care? Are there challenges and lessons learned that we can also apply in the non-veteran population? Now, I want to introduce our panel. So today we're going to be joined by Carrie Farmer, who's the co-director of the Rand Epstein Family Veterans Policy Research Institute and director of Rand Healthcare Quality Measurement and Improvement. We're also joined by Dr. Maggie Allard, founder and CEO of Community Health Design Institute. We're being joined by Nathan Lutke, a healthcare administrator and public health leader. And we're being joined by two colleagues from the Meadows Mental Health Policy Institute, Hanna, who's the Senior Director of Veteran Initiatives, and Tempest Sherrill, Senior Director for Strategy and Innovation. Now, as we kick things off, I'm going to go to each of our panel members and ask them to tell us a little bit more about themselves and also about the work they are doing supporting veterans and their families. And Carrie, I'll kick it over to you and let you start us off.
Great, thank you so much. Thank you for that introduction. So as Sam said, my name is Carrie Farmer. I am a senior policy researcher at the RAND Corporation. For those of you who aren't familiar with RAND, RAND is a nonprofit, nonpartisan research organization. I've been at RAND for 12 years. My research focuses on improving access to high quality healthcare for veterans and service members. I've studied issues around how veterans access care from VA and from community providers, the quality of care provided by both VA and community providers, and barriers that veterans experience accessing healthcare. I'm also the co-director of our new Veterans Policy Research Institute. Our mission of the Institute is to conduct evidence-based research to improve the lives of those who served in the U.S. military. I'm really grateful to be here today, and I'm really looking forward to this discussion.
Great, thanks, Carrie. And let's go to Dr. Maggie Allard from the Community Health Design Institute.
Hi, everyone. It's such a pleasure to be here. Sam, thank you for inviting me onto this panel. First of all, just a heartfelt thank you to the men and women who serve and have served in our armed forces. Your sacrifice and dedication to this country is not forgotten and is greatly appreciated. So I recently started the Community Health Design Institute truly because of the severe lack of healthcare access throughout the country, not only for veterans, but for a variety of populations, much worse in rural areas, but also in high density urban areas. So we at CHDI seek to advance innovative healthcare teams, including community health workers and a newly burgeoning field of community paramedics, who can bring care directly to the home and the community and even to the homeless wherever they are. As well, we seek to equip these innovative care team members with the technology to communicate with the larger health and social service network remotely from the field where they're practicing. Also to do remote documentation, to be able to order referrals for social services from the field, and to be able to monitor patients remotely. So we feel that equipping innovative healthcare providers with this type of technology really advances care in vulnerable populations who need access. Thank you.
No, thanks, Maggie. And let's go over to Nathan.
Good morning, Nathan Lukey. So I spent the last 15 years working in both public health and healthcare administration with focus on serving rural areas and underserved populations, and really focusing on those areas where our at-risk populations intersect, including veterans in the rural areas, which is a large percentage of our veterans actually live in those rural areas. And so assuring that we're meeting them at that intersection, having shared experiences, pulling them into any of the prevention efforts, and also assuring that high-level services are provided wherever they may be.
No, thanks, Nathan. And now we're going to go over to our panel member who's going above and beyond the call of duty today. I guarantee you he's not physically driving right now. He is stopped. So, Hanna from the Meadows Mental Health Policy Institute, who's traveling, but great to have him here as part of the panel today. Over to you, Sean.
Yeah, great. Thanks, Sam. I appreciate it. Yeah, so Hanna, Senior Director of Veteran Initiatives, as part of the policy implementation team at the Meadows Mental Health Policy Institute. Some of my background as a Navy corpsman, served with the Marines in the 90s. Federal government sent me on a nice little vacation to Somalia in '95, so got to see a little bit of stuff there. Subsequent to my service, I got out in 2000. I studied traditional Chinese medicine. I'm a licensed acupuncturist. I'm not practicing anymore because as I was standing up a complementary and alternative medicine program for veterans and their families, I met the Samaritan Center in Austin, and they brought me and my team in to integrate what we were doing with complementary and alternative medicine with their mental health program, their clinical mental health program called Hope for Heroes. And from there, I got involved in peer support, both at the VA and at the community level. There was a small state initiative that Texas was putting out that eventually I worked with the Department of State Health Services and all of our local mental health authorities across the state to implement the Military Veteran Peer Network. So 37 coordinators across the state tasked with recruiting, training, supporting, and rewarding veterans and their families in support of other veterans and their families. So outside of the offices, in the field, community-based peer support. Subsequent to that, I became the director of veteran mental health at the Texas Veterans Commission, where I oversaw that state program. And then about 6 years ago, came over to the Meadows Mental Health Policy Institute to take the relationships that I built and the experience that I had and help the Institute build out its technical assistance to community-based programs across the state. So now I have the pleasure of working with the leading organizations, community-based organizations across the state in helping to meet the needs of veterans and their families outside of VA, but then integrating with VA. So I really look forward to this conversation and bringing what I can and mostly learning.
No, thanks, Sean. And now let's go over to one of Sean's colleagues at the Meadows Mental Health Policy Institute, Tempa Sherrill. Tempa, over to you.
Thank you so much, Sam. It's an honor to be here. And a little bit of my background, I actually connected with Sean a few years ago in the community space. I am a licensed professional counselor, and I've been in the mental health nonprofit community service space for the last 10 years. It all started with my experience as the spouse of a veteran, Marine and Army veteran. He served in Afghanistan 2008 to 2009, and we were a reservist family. So his day job was police officer. And I really connected with Colonel Sutherland's story of when he came back, and that piece of the tears in his wife's eyes as he when they were in the car, and that was it for me. Like the nuances are so complex for families and the experiences, and so that fueled my passion to go back to school. I was actually in education at the time, teaching high school, and I had a fire lit inside of me. I went back to school, got my master's in counseling and psychology, and said, I want to make a difference. I want to do something for the families who are experiencing these life-changing things as a result of this war. And so the impact on our family helped me understand it on a level that a lot of other practitioners don't understand. So I set out to developed 2 programs for veterans and eventually also for first responders, and around trauma and the effects and impacts of trauma on the veterans and their families. I founded a nonprofit and a program called Stay the Course, and that's where Sean and I met in that space. And I've just recently come over to Meadows, the Institute, and am joining the work and efforts on a more statewide global level. So I'm here to speak from that lens, and I'm really happy to be a part of this conversation and to hear from all of you.
Thanks, Tempa. So I'm going to go ahead and jump right in. I think is probably the overarching question that we are addressing today. But just before I do that, I do think it's important that when we talk about veterans, we really think in terms of who veterans are. Because in my experience, working in the veteran space, that there's this perception that when you think of a veteran, you think they're male, white, and older. That is kind of the common perception of what it means to be a veteran. But I think it's interesting if you look at, especially our post 9/11 generation, if you look at that generation, you really get a feel for the uniqueness of veterans' health needs, as well as the diversity that's actually resident in our veteran population. For example, 30% of post 9/11 veterans are women, which is double of what it was during the Vietnam service era. The male post 9/11 population is more diverse than other service areas, with almost double the number of non-white veterans, 20%, and more than double the Hispanic veterans, 11.5%. And the female post 9/11 population is even more diverse than that, with 32% non-white and 13% Hispanic veterans. And about 75% of post 9/11 veterans are below age 44, with a median age of 33, while veterans from other service eras are mostly above age 55. Unfortunately, that's the category that I'm in. So I think it's important to understand, to give that context as we have this discussion, is kind of this monolithic view that many people have of veterans. When you start to break it down, it's just not true. It is a very diverse, veterans as a whole are incredibly diverse, and as well, they have unique health needs, which sometimes can be challenges and obstacles in making sure they can access healthcare. So here's the question. With that in mind, with that as the backdrop, what are some of the challenges accessing healthcare that you have seen in your work that veterans face? Not only our post 9/11 generation, as I just went through, but also really veterans from all eras. And Carrie, if you could start us off, and then from there, I'll go to Maggie, then we'll start to go around the panel again.
Sure. So, Sam, as you referenced earlier, I think there's this common misperception that all veterans get their care from VA. Really, it's not only do not all veterans get their care from VA, but not all veterans are even eligible to get their care from VA. So of the 19 million veterans, 9 million veterans are enrolled in VA healthcare, and in a given year, 6 million veterans receive care from VA. So the rest of the veteran population is getting their care from other sources. And even among veterans who are getting care from VA, they're not getting all of their care from VA on average. So many veterans not only have access to VA healthcare, but they also have healthcare through their employer, or they may also have TRICARE, or they may, for older veterans, also have Medicare. So they're getting care from a variety of sources. So I think when we think about veterans healthcare, of course, VA is a huge consideration, and we pay a lot of attention to VA healthcare. But we also need to think about all of these non-VA healthcare sources and what are the barriers that veterans may face from those sources. One of which you referenced is, and that Colonel Sutherland referenced too, is sort of understanding military experience and being military culturally competent, and being able to understand the unique healthcare needs of veterans, understand the available resources, even asking, are you a veteran, to all patients, to really even have, a provider is not going to know necessarily that the patient sitting in front of them is a veteran. So even initiating that conversation. But one other thing I want to throw out there is that it's not just accessing care. So just getting in the door and having a visit is not sufficient. It has to be high quality care. There are lots of poor care out there, and really making sure that we are setting up structures so that veterans are accessing high quality care, that providers are providing high quality care, and that we really ensure that that it's not just getting to the appointment, it's just that they're getting the care that they actually need.
Thanks, Carrie. And Maggie, let's go over to you.
Okay, I just wanted to give a little bit of background. I don't know if I did that during the introduction. So I've been a physician and internist in underinvested communities for about 25 years. The majority of my work with veterans has been at a VA during training, but also veterans of lower socioeconomic strata as a medical director for complex populations over the years. So I think there's really three things with access. One is difficulty accessing healthcare resources. Secondly, there's a difficulty transitioning into the civilian population. And then finally, it's social determinants. So I'm going to be saying a lot of the same things that Carrie has just said from a slightly different perspective. So as far as difficulty accessing healthcare resources, not all VAs are created equal. So if you're in a big hub city like Denver or Boston or Cleveland, you are going to have a robust set of resources for employment, for job opportunities, that kind of social determinants care, for housing and housing insecure patients. You're going to have behavioral health resources and PTSD counselors who are trauma informed, and you're going to have a variety of types of specialists. But if you're in rural areas, this is often not accessible. And this is worse for female veterans and for minority veterans, especially in rural areas. Then the second thing is that there is a real difficulty transitioning into the civilian population. I have seen this in my post-release patients who were recently incarcerated or incarcerated for many years. I've seen this in refugee patients. So in those various populations and also in my military veterans, where it's sometimes it can take 1 to 2 years, and there's this kind of confusion, there's anxiety, there's depression that just comes from the transition itself, and that takes a while to get over. With veterans, whether or not they have PTSD or significant mental health issues, I see a hypervigilance and an alertness, which is part of their training, and actually it is not a pathology, it's just part of who they are. There's also a stoicness. So sometimes there's a reticence to inform me about physical health issues, much less mental health issues. And so because veterans may advocate less than my other patient populations, they may get less care. And the VA is often a really good midpoint for care because it still has a lot of military culture. There's a lot of structure. You only get a certain number of appointments. Things are very regimented. But I think it's very different when you come to physicians who are trained in the Western health system, where we're supposed to ask open-ended, touchy-feely questions like, how are you doing? And we're supposed to engage patients in this back and forth dialogue and set care goals together. And so sometimes initially, especially after being on tour, it may be difficult to access that kind of care. Finally, there are, with civilian care, care can be in different buildings within the same city or in different cities altogether. So geographically, even for my non-veteran patients, it's very difficult sometimes to access all the pieces of care. And then as far as social determinants go, housing insecurity often comes from two things. It can come from mental illness and or substance use. In my veteran population, I've seen more, the substance is usually more alcohol. And when you have folks who are housing insecure or homeless, it is more difficult for them to access care. Simply for everything from transportation to getting medications stolen or not being able to get reminders when there are visits. There are so many barriers to getting to a clinic, to getting to a pharmacy, to sticking to a care plan. And social determinants very much affects that.
Thanks, Maggie. I have that are some great points, and I'm interested in kind of following up on a couple of these. But I want to let's go over to Nathan, because I know you definitely have a perspective, especially on some of the challenges in our rural communities that Maggie highlighted there. So Nathan, over to you for your comments.
Sure. First, I'd like to pull it to the bigger picture. I mean, if we consider any of our own personal experiences, utilization of healthcare is complex. It's complex if you've got great healthcare, know what you're doing, are working, have privatized healthcare, have access, all of those things, it's still complex, it's difficult. So when we layer upon that a second option, so a VA option, which is essentially a social medicine model, which may simplify some pieces, but lacks the flexibility. It's low in cost, may even have incentives for you. And then you've had this other option that is entirely different, functions differently, essentially a fee-for-service option. The private option gives you that level of flexibility. You might be looking for some specialization that you couldn't see otherwise, and even just the option of choice, but may impact your pocketbook a bit more to go that route. Every clinical medical decision you're making is balancing these two different systems that, quite honestly, people working in them sometimes have a hard time understanding, right? So I think the access issue can be as simple as the complexity and, you know, our general response to something that evokes fear, anxiety, it's overwhelming, is avoidance, right? And that's compounding a risk factor that already exists for veterans. So when you look at, you know, an older veteran who's going there and did everything they could through community care to make sure it was set up so it would be billed properly, that this would be handled correctly, that all gets missed, simple registration error somewhere in the process. The default is going to be a Medicare billing. That Medicare billing then causes a further down the line issue for VA, who doesn't do partial reimbursement. So just a quick example of how something as simple as, I thought I had it all set up. I went in there, I took care of everything. I had my I's dotted, T's crossed, walked into this alternative site for care, and now the billing is another obstacle for me. All of those lends itself to avoidance or apprehension for that next time you go to seek care. And, you know, when we consider the rural options, I mean, we have a number of risk factors there, of course. The rural population in general can be characterized as having, there's going to be more of a lack of trust or concern when it comes to engaging with government, with large institutions. So again, pulling back and not necessarily jumping in when you think that perhaps I need to seek care, whether that is mental health or anything else. So I think that that first step of making it easy for a veteran, for anybody to engage, is all overlaid in an already complex system that we don't do great. So I guess that would be my first and foremost concern when it comes to access for veterans.
Nathan, while you were talking, I was smiling a little bit because I could have sworn that maybe you have like a camera over my shoulder for my last 2 years since my retirement, because I went from, in my time in the military, a very simple system. And I don't think a lot of people understand when it comes to healthcare in the military, it's a somewhat very easy to navigate. If I had an issue, I just go on sick call, or I go down to the troop medical clinic, which is on every installation. A lot of our installations have hospitals on them, fully staffed hospitals, and go to that or into the local community. It was just very easy. You have a problem, you just go, and the problem gets resolved. And then, you know, fast forward, once I retired, I entered that very complex system you talked about, and it can be incredibly frustrating. And when you talked about how the reaction is avoidance, I was just like, yeah, that has described some of my interactions with the civilian healthcare system. And so I understand that frustration and those challenges very acutely. So no, thank you for that. Okay, let's go over to Sean for his thoughts about some of the challenges veterans have accessing healthcare.
Sure. And, you know, within the Institute, we talk a lot that mental health care is healthcare. It's all healthcare. And we have it siloed off in our society, in our systems, like mental health is over there somewhere, where we know that 80% of depression can be treated in primary care. It's not screened for universally. And so then it's not treated. If you don't ask, you don't know, right? So like anyone who goes into the doctor, doesn't matter what you're going in for, they're going to take your vital signs on the way in through the door. Now, if you're coming into the doctor and you've got knee pain and they take your vital signs and your blood pressure is 210/160, they're not going to be talking to you about your knee today. that's now become a cardiac event, and because it's a life-threatening condition that you just walked in with, they're going to go to that. Your knee is getting put behind you. And we could do the same things in primary care if we had universal screening of mental health conditions, just a PHQ-9, something. Every time a patient comes in, screening for mental health concerns universally, then we could identify them. But why don't we do that, right? Because everything has to have a bill code. Everything has, because it's just the way our system is set up. That now you're encumbering, you're taking more nurses' time, more screening time, more doctor time for something that their practice really isn't set up for. So it's taking universal system change. It's going to take all of us to make a difference in this. Now, the VA, to their credit, does universal screening in primary care. Like every time I go to the VA, they're asking me about my sleep, they're asking about my drinking, they're asking about my stress. Like all of these things are universally screening. And if I screen positive on any of that, they've got a specialist that's coming to talk to me right there to do further screening to see if this is something in order that if I'd be willing to go to treat. And my cohort, my peers, we all experience that when we go to VA. But I'm one of those people that doesn't go to VA except maybe once a year. I use my private insurance and get treated out in the community because the VA is not convenient to where I live. It's not that I don't appreciate their care, it's just the time, right? When I can schedule a doctor wherever I want, whenever I want, but I go in and I'm not getting culturally competent care. Whatever my chief complaint is, they're asking me about. And there are some days that would probably be beneficial if they did do more of the how you feeling, how you doing. In fact, you notice I'm on the road. There's an initiative that we're working on as it relates to children. The Institute has worked with our government leaders and the leaders of our state medical schools to implement a program called the Child Psychiatry Access Network. I'm literally going into pediatric offices and letting them know about this no-cost network that they can be a part of, where they can get consultation in primary care from the lead psychiatrist, lead child psychologist, and psychiatrist at the medical school to get children universally screened and right to get these things treated early. But it's an evolution of a system that is slow. And when I go into these doctors' offices that we've been calling, we've sent them materials, they're not enrolling. They found it in, so they're not enrolling. I go in, they're busy. They're dealing with COVID. They're dealing with sick kids and all kinds. Like they're just super busy, and it becomes something else that they need to do that we're adding on to their plate. So we've got to figure out how to do this where mental health care is just health care and it's universal with the rest of it.
No, that I think that is a great reinforcing comment to Carrie's, talking about how the lack of a kind of military cultural competence among providers. And that's a great example, Sean, that you provided about the idea of universal screening, something that happens as a matter of routine. Well, not only in the VA, but also in military health facilities. That happens as a matter of routine. But that's, as you pointed out, that does not happen as a matter of routine or happen at all as you go into maybe a private provider or a community health or a provider there in the local community. That's a great point. So Sean, or I'm sorry, Tempa, let's go over to you.
Thank you. And yes, to echo what many of the other panelists have already said about the complexity of the larger global system, I'd like to just reiterate that. And the need for universal screening, the need for the connection of mind and body and the treatment of the whole person. And back to Colonel Sutherland's comment about the approach of wellness rather than pathology. And if we can look at the whole person and treat the whole person, studies have already shown what that looks like, and it's successful. Multidisciplinary teams are successful in the trials and research that's been done. So through my experience in working in the community nonprofit space, what I've seen over the last 10 years is veteran after veteran after veteran bringing in their reason for seeking out help in the community is because of the hoops they have to jump through, all of those steps and the roadblocks that they run into of getting the help they need, and they give up. You know, that window of opportunity gets closed. And so that's why the grassroots organizations and movements across the US are successful, is because we're filling that gap. You know, there are a lot of organizations and companies who are trying to think outside the box, which is why we're here today. So waiting lists, the overwhelmed system, the fact that families aren't served nor are they identified. So along the lines of the universal screening, you know, for mental health in general, we aren't screening to identify the veterans and the veteran families, the children of veterans in schools. You know, that is cultural competence. And back to what Dr. Sutherland said, the general population doesn't know who we are. Well, no, they don't. They don't know where, and these families exist all over in every community in America.
Yes, thanks, Tempa, and also I think it's important, as you just did, you kind of, you know, we're not just talking about veterans here. We're talking about their families. We're talking about the children of veterans, and making sure that they have access as well. And they have unique challenges, especially the children of veterans. I know this is an area that there's been a lot more discussion about in recent years, about some of the unique, especially mental health challenges that the children of veterans have as well. So I think it's important to bring out. You know, I thought it was interesting. Nathan talked about the complexity of the healthcare system and the challenges with navigating that. And then Sean talked about, in terms of providers, kind of, you know, not being in tune to the needs of veterans and their families, and also understanding what is available to support them. And I'm taking a very long way to get to Carrie, because I know Carrie was involved in a study focused on New York State, and I think if I'm right, Carrie, that was one of your observations or conclusions, was this idea that a lot of our providers, there's an education component for veterans that they need to understand to navigate the healthcare system. But there's also this education or training component that providers need to embrace as well, so they understand. Like Sean's out there right now trying to educate providers on a particular program, but you found in the report in New York State that many providers just are not in tune to some of the programs that are available to support veterans and their families.
Yeah, that's right. In that study, we applied a definition of readiness to treat veterans, and that encompassed understanding military cultural competence, or having taken some sort of military cultural training, providing evidence-based medicine, asking about patients are veterans, and a number of other factors. And 2% of all providers met the readiness criteria. So that's a very, very small proportion of providers that we could comfortably say this is a provider that, you know, we would be sending veterans to, that is providing the kind of care we are expecting. So there's a lot of work to do, and there are a lot of challenges. I've been thinking a lot about VA community care, and so as several of you have noted, VA has a lot of processes in place in VA facilities related to training, and training around suicide prevention, and training around screening. And VA community care providers, and even beyond, that's sort of one subset of providers, but even and then beyond that, providers who aren't involved with VA whatsoever, there's no requirement for that kind of training. And VA and other organizations like Psych Farmer make a lot of trainings available in terms of understanding veterans. I mean, Psych Farmer has a 15-minute training, which is great, which is a really good basis. And even if all providers could take the 15 minutes to watch this video on 15 things veterans wish you knew about them, that would go a long way to even starting to think about this, but there's no mechanism to make that happen. Providers have to want to do it themselves. There's no incentive to do it. So I think that's one of the big challenges, is how do you change provider behavior to improve their ability to provide quality care to veterans.
Just a quick follow-up to that. Do you think there, in terms of incentivizing provider behavior, I don't know if things like the Mission Act, the push, I guess it's been what, 2 years now since they started implementing the Mission Act, where it was going to increase the ability for veterans to go outside the VA system to get community care. What are your thoughts about that, Carrie, in terms of, is that a way to incentivize provider behavior, the opportunity to participate in that program?
No, because the contracts with providers don't require it. So it's not, when VA was setting up the contracts, it was, something that I think VA was interested in, but the managed care companies were not interested in. Their concern was about attracting providers to the program. So if you put more requirements on providers to join the community care network, the fewer providers there will be interested in participating. And so unfortunately, that's those types of requirements are things that are not in the contract. So it has to be, sort of from a policy perspective, that contract could be revisited. There could be modifications to require that. But I think there also has to be education of providers to try to, if it's something that can't be required, it should be desirable in some way to either from a patriotism perspective, really providing the best care possible. I really think that providers may feel more comfortable treating veterans if they had some understanding about veterans. So I think that it's a lot of things. And Sean, I'm interested in sort of from your perspective of trying to convince these pediatric practices to join a resource. I think there might be similar barriers there of here's something that could help you, but it does require some work on your part.
I'll tell you, Carrie, because it's fresh right now. Yesterday, I was doing these same visits, and there's one that really stands out to me. I was talking to the office manager, and they have 4 pediatricians there, and she's like, "What is this about?" I explained the program and how it works, and it's a resource, and this is to help y'all better identify children with mental health issues, and then treat them here. And she's like, "Yeah, they're not going to do that." No, but you could. She looks at, and it's just me. We're talking. She's like, they're not going to. Like, they're not going to treat it here. And I go, well, you don't have to, but somebody needs to. Like, somebody needs to treat these kids. And if it's not in your will, it's great. Screen them and let's get them somewhere else, because they'll also help navigate them to what payers do they have, what insurance, are they Medicaid, Medicare, whatever. Like, help them navigate to get to it. But they're in your office. Like, at least ask them, are they doing okay? Is there anything? And then let somebody else take it. And this is where I was like super excited for the past years to work with the IVMF on their Texas Serves initiative, part of their America Serves, using the Unite Us platform to tie together providers in the geography, where we talk about educating providers and having them better understand veterans or better understand particular ethnic groups or whatever the cultural experiences are. But I think we have to be reasonable in our expectations of how many different cultural trainings and population trainings. Like, when this person's real job is to be a subject matter expert on medicine, what do the labs say? What do the tests say? What's the diagnosis? What's the best treatment? What are we getting our outcomes? That there are other ways to approach it rather than everyone having to be an expert on everything. So it's like when we look at resource navigation across the social determinants of health, like Dr. Allard was talking about, you have Combined Arms is an example in Texas of resource coordination. I know Easter Seals and has their, I can't remember, I believe Colonel Sutherland mentioned it, but Easter Seals has their coordinated, in communities, their organization, United Way is doing it, the IVMF and their America Serves, so that the idea is any provider, do what you're best at, do what you do, what you're funded to do. Try and identify, while you got the person, if they have other needs, and then get them to a community organizing third party that does that resource navigation, rather than every organization having to try and know every other organization and all their programs. Like, they just can't. To make that direct referral, we have the technology and we have the ability to have resource coordination done in communities where now we can just screen. I do what I do. I'm doing housing. I screen for other things. There's other needs. I give it to that third party to navigate those things. Those solutions exist, and I think are going to be critical for us moving forward and beyond the veteran population, like for other populations as well.
Let's go to Maggie.
So, I mean, so many comments on what was just said, but I think, you know, I'm going to date myself a little here, but looking at the domestic violence movement that was in the 80s, and then there was disparities that started in the late 90s, early 2000s, and then we went into human trafficking, which was around 2010 forward, and then a bigger push into cultural competence, and now we have a lot of different things on the table. But with each of these, the way it got into medical school education, the way it became an essential training for physicians for continuing education, is by speaking to the overarching bodies. So it would be potentially, and we can talk offline on how to strategize about this, but the medical school governing bodies and the American Medical Association, the American College of Physicians, governing bodies have to get involved so that this becomes an essential training. So that's one piece, and of course that's state by state. Some states mandate things a lot more, like where I've practiced in Massachusetts, there is a variety of trainings we have to do, so it just has to be mandated in that way. Regarding screenings, you're absolutely right. There are certain payers, there are certain ACOs that require mental health screenings, and there are others that don't. So we're really talking about this moment in our country where we really need to have healthcare and social service integration. And there needs to be just a set of screenings across the board. Healthcare is no longer, you know, biological care, it's biopsychosocial, and we need to really embrace that model and bring everyone to the table. A big part of that is technology, EMR integration, communication platforms, bringing communication together. So the panelists are correct. The time is now, and we have the resources to do this. We just have to do it smart and do it together.
No, thanks, Maggie and Sean and Carrie. That was a great conversation. I wanted to go over to Nathan, and I know that we talk a lot about. I think a lot of our conversation we're talking about accessing healthcare is a very kind of reactive. You know, it's all about reacting. Someone has something that's wrong with them, then they go and have it addressed or try to have it addressed. But an important component of healthcare is also the preventive side, of the more proactive side. So I know you've been involved in some of this work in trying to come up with preventive strategies when it comes to healthcare. So, you know, if you could make some comments about that, and then if there's any parallels to veterans and their families, if you could bring those out as well.
Sure. So, you know, I'm thinking about this. I think I want to start by framing the question a little bit. So when we talk about, you know, community-based or preventive strategies, depending on the context that you're discussing it in, it's going to mean very different things, which we don't do ourselves, and, you know, we don't help ourselves at all with this issue. But if we're talking about clinically and we're talking prevention, oftentimes that right quickly goes to screening, immunizations, preventive medicines, behavioral counseling, weight management, those sorts of things, which are all important preventative measures that we take on the clinical side, but are only truly a community-based in the same sense that, for example, the VA refers to what we would think of as a local clinic as their community-based outpatient clinic, or the CBOC. In that sense, yes, it provides better access. You have primary care usually closer to you, but that is the limitation of those preventative strategies. And it's going to be up to those screenings we're just talking about to track somebody in the proper direction. You know, VA has done a great job of addressing, you know, key social determinants issues, getting down to, you know, improving the physical activity, how somebody can better use their built environment, dietary needs, what kind of personal practices improve and educate you on those things. Those are all things that might be an intersection. But when we're starting to get public health and we're talking about preventive strategies, it's all around the social determinants of health, right? So it's primarily around your socioeconomic status, your education, your built environment, health access, those sorts of things. And so when I step back and think, what's really interesting after listening to Colonel Sutherland discuss what it means to interact and engage the veteran community is we lack an interface in so many places in order to accomplish that. There's so much great work out there that lacks this interface. So for example, if I'm looking at physical activity, because that's something that can be encouraged, maybe even a program or a gym or something like that as a connection when you raise concerns about weight management or something to your primary care doctor. But in public health, what that looks like is, I'll give a quick example of initiative called Complete Streets. So it's been around for 15, 20 years. It's been around for a long time. It actually has been coming up in a lot of federal policy and discussion around infrastructure. And what it is making sure that our neighborhood streets are safe for biking, walking, cars, public transportation, everything, so that we have a community we can get out and interact with. So it not only increases your physical activity, but your social engagement. All great policies, all great practices, and when we're able to put them in place, have the potential to impact a veteran and their family as well, because they may very well find that they've been prescribed the, you know, get out and walk, get in nature, take a step out of your front door, try to combat some of these isolation tendencies that you've developed since you've returned. And having a community that is built to support that creates that advantage. However, unless there's a specific means of engaging a community, cultural competency across the board, right? Whether it's a minority community, veteran community, rural community, you can't build it and they will come. So I think that you know, some of the others on this panel probably could get better into examples of specific community-based programs that do exist that draw that connection. And I think Tampa talking about how we are the network that fills that gap is really spot on, because in general, even our best placed policies aren't necessarily going to impact veterans as directly as they potentially could. Now we take that to the rural environment as well, where that impacts them entirely different, right? So that same example I give you of Complete Streets, well, in a small community, maybe they're already a bit more safe, but the truth is they're a lot more sparse. So they're difficult to have that same physical activity, because yeah, it's green from here 5 miles into town, but it's all 55-mile-an-hour road. So if you're a veteran living 5 miles out of town and those are your options, getting off of your front porch still can be a challenge. So we need to find ways to interface, I think, to make a community-based option that much more of an advantage for our veterans and other underserved communities.
Tempo, your thoughts on that? I just want to follow up in terms of that idea of kind of coming up with those community-based options or solutions.
Absolutely, thank you. Yes, Nathan, I completely agree. And that's what I have observed and heard over the last 10 years, and have been involved in lots of organizations who, you know, veterans need to be connected to their community. They need to be doing something. They need to be doing things that give them purpose. And that is incumbent upon the community to interact and engage. And with that concept that you said, Nathan, build it and they will come, not necessarily. We have to reach across, you know, and interface that somehow. So getting them doing something outdoors, or, you know, there are a multitude of things, and at the core of that is peer support, right? They're getting support from maybe like-minded individuals or civilians even, and bridging that gap between the military world and the civilian world. So I believe that building connections, and Colonel Sutherland spoke to this, is one of the main keys to prevention. That's the bridge. Instead of looking at pathology first, the best prevention is to create these opportunities for connection and getting veterans and their families doing something and finding purpose.
No, that's a great point, and I just, you know, something that I share with as many people as I can when I'm given the opportunity is that I don't think a lot of people understand that when someone transitions out of the military, the loss of camaraderie and the loss of those strong bonds that have been developed in the military. I won't say that's unique to the military. There's probably other areas in our life where you can develop those strong bonds and that sense of camaraderie, but I can't find, I've yet to find kind of a better example that I've seen in my own personal experience in the military. Being around a small military unit, whether Army, Marines, Navy, Air Force, whatever it is, being around a small unit and seeing those young men and women interact with each other, I mean, you can just sense kind of that togetherness, the strong bonds and camaraderie. And that's one of those things that once you leave the military, in many ways that disappears. And that's a huge gulf that has to be filled. And I think we've all been touching upon this, but here we're talking about accessing healthcare, but we're really talking about overall wellness of veterans and their families and creating positive outcomes. And I think being able to do that, not only is it good to overall wellness, but I think is a good preventive strategy when it comes to how you manage your healthcare as well. Or it's a good preventive strategy to negative outcomes that could potentially come up when we talk about healthcare. So I appreciate you for bringing that up, Tempa, and Nathan as well. That was very good. I want to go back, if we could, Maggie, go back to you, because I want to talk about healthcare deserts, because I know you've done a lot of work in this. You mentioned it in your, I think you mentioned it in your opening statement, because I think there's this perception when we talk about healthcare deserts, everyone immediately goes to these rural communities. Like, Nathan was talking about, you're in a rural community, you may live 5 miles out of town, it's a very sparse population to begin with, so there's not a lot of either providers or facilities there to support not only veterans, but to support other folks that are in those rural communities. But I know you've done some work where, those healthcare deserts actually can be in metropolitan and in urban areas as well, because it's not just geographical distance that creates a healthcare desert. There's these other factors as well. So I wanted to give you a chance to talk a little bit about that.
Sure. In high density urban areas, we see healthcare deserts as well. We see food deserts, and we see, high crime. There are a lot of things we see in high density areas. But for example, I've worked in Denver and the Bronx and in Roxbury and Lowell in Massachusetts. And in all of those areas, when I was at a federally qualified health center, we had a lack of nurses, doctors, behavioral health professionals at various times during my time there. And those are in very dense areas. It's just because the number of hundreds of thousands and millions of people who live in those areas have very complex needs. Again, biopsychosocial, and one primary care physician, one nurse, one social worker, one social service agency is not enough to bridge all the gaps. So you will see healthcare deserts in those areas as well.
I'm going to go back a little bit because I meant to bring this up when we were having the discussion about some of the resources. So I'll work with our partners there in Consensus Health, and we'll look at figuring a way to identify when we're talking about, I think when we're talking about Psych Armor, and some of the trainings available. I think Carrie brought that up. That really cued my memory that there are a lot of great resources out there. So we're going to figure a way to put this and get this out to the attendees, some of the resources like Psych Armor and some of the others that have been mentioned as well, getting those out there so people know what's out there. So we'll figure a way to do that. What I like to do is, just talk about resources that are available out there, is just, if we could just kind of go around the horn. And if there are some certain resources, or not only resources, but if there's certain reports or studies that you think are important to this conversation, give everyone a chance to address or to speak to some of those. And I'll start with Carrie, if that's okay.
Sure. So I, not to totally toot my own horn, but we have a number of reports related to veteran healthcare available on through our Institute website, which is veterans.rand.org. We have a couple of reports which I think are really useful. They're dense, so I'm warning the audience about VA healthcare. So really understanding the healthcare needs, the unique healthcare needs of veterans compared to non-veterans, as well as the healthcare that VA provides and what the evidence really shows about access and quality of care. So one of those reports is definitely outdated at this point. It was in 2015, but the information about, if you want to understand who's eligible for VA healthcare, what kind of care is provided by VA, where are VA facilities located, that helps to paint the picture of what's part of this map and network and available resources for veterans. And I'm happy, Sam, to share with you some links that the audience might be interested in, as well as the report that you mentioned, understanding the readiness of providers to treat veterans, and what some resources may be.
No, that'll be great, Carrie. We'll figure a way to get those links out to the audience. And I don't think, after looking at some of them, I don't think they're necessarily outdated, because it's interesting. Even going back to 2015, you'll see some things going, yeah, that's still a problem. That's still a challenge.
I'll tell you one thing that I think is outdated from that report, which is the report on access and quality of care. There's half of, I'd say the access piece may be outdated, and that's because that report was a congressionally mandated study after the big crisis that prompted the passage of the Veterans Choice Act in 2014. And so at that time, there were big news articles and a big outcry about veterans waiting for a long time for care, being on waiting lists and dying while they're on the waiting list, like really the huge scandal that caused the secretary to resign. And so since then, VA has made a very concerted effort to improve monitoring of access and opening more appointments in the community as a way to free up additional appointments. So I think the access issue has likely changed. There hasn't been a comprehensive study of it since then either. So the extent to which it's changed, I'm not totally sure. On the quality front, I think that is not outdated. The study after study shows that VA provides very high quality care, and that is at least as good and in many cases better than non-VA care. But to Maggie's earlier point, there's a variety of VA facilities, and quality of care is uneven across those facilities. So I think that's another thing that has not changed, and thinking specifically about VA care, sort of making sure that all VA facilities are providing the same standard of care is an ongoing challenge.
Thanks, Carrie. And Sean, let's go over to you in terms of, if there's any resources or tools that, and I know that you mentioned some organizations there in Texas that are very helpful. If there's anything else you wanted to highlight?
Yeah, I think I would want to highlight the ETS sponsorship program that is relatively new. It's a joint VA, DoD, and private partnership program. The period of highest risk for suicide in veterans 18 to 34 years old is the first year that they got out. It's the deadly gap, right? And just like you talked about, Sam, where, you know, it was easy to engage in healthcare when you're on active duty. You just go down to the battalion aid station, you see a corpsman, right, or an army, you see a medic, they do what they do, they send us the doc, like it's just right there, it's embedded. And so what this is doing is they're training sponsors across the country. It's part of Soldier for Life TAP. So anywhere in the world, a soldier getting out, they're piloting with the Army first. A soldier getting out, they'll see if you're going to one of these 6 cities or 10 or however many they have now, you can have a sponsor. A year to 6 months out, have a sponsor, a live human being that you can be talking to that can tell you about the community, the neighborhood, the schools. In the same way, if you have a sponsor when you PCS from one base to another on active duty, it's creating that transition. And they've been doing it for about 6 years in New York City. So soldiers from Fort Drum going to New York City, one of the 7 boroughs, could get a sponsor. They also have the technology in place so the sponsors aren't overwhelmed trying to be case managers. Technology's in place. They can identify the need, put it in the system, and get them navigating the system. So I think that's a really important program that is happening now between the VA, the DoD, and local organizations to implement as a resource to fill that deadly gap. And then just any opportunities that we have with primary care. We're going to be doing a pilot over the next couple of years in the Central Texas area, the Austin area, with a primary care, civilian-based community primary care organization, identifying their highest population clinic where veterans and their families may be going, and working with them to do universal screening. Did you ever serve in the military? Did a family member ever serve in the military? And if they say yes, here's a brief mental health screening to see if there's anything, and then using community organizations to make that referral, right? Get consent, get that referral, and then have someone else help that family member or veteran find the resource that they need because they know the communities, rather than waiting for the doctors or the case managers or social workers to try and know everything, right? So we're going to be piloting that. I think that it's everything that's been talked about are the resources.
And Tempa, did you have anything else you wanted to add in terms of resources or tools?
I do want to, on the mental health side, as far as a national nonprofit effort with the Cohen Veteran Network, they're multi-state, culturally competent provider of services to veterans and families and active military as well. They serve veterans of mostly all eras, I believe. You know, and more nonprofits are opening up to all eras and not just post 9/11. But that's, you know, a very good one. And there are multiple organizations like Cohen in Texas as well. And then as far as military cultural training, cultural competence, Psych Armor is amazing. I've utilized Psych Armor with new staff members over the years. But SAMHSA actually and the VA have great resources if you dig, you know, into their resources that are available to anyone. SAMHSA has a whole section of, you know, standards and cultural competence training suggestions on their site. So, you know, if you look hard enough, you can find what you need if you really want to find it.
No, Tempa, you're right about the VA. Lots of information on the website. I don't know if I would call it the easiest to navigate. You could spend, like I said, there's a lot of information. You could spend a couple of days working through that, but no, you're exactly right. And Nathan, what about you?
So I think first I'd actually reference back to that RAND report regarding physician readiness to treat our veterans. And the reason I start there is I think there's an enormous conversation that's not being had. And that report uniquely highlights that. Having been somebody who I worked intensely with providers and physician relationships for many years. And I have a number of physicians who were trained, grew up in the military. Their first surgical experiences were, you know, in Iraq and Afghanistan, who are profoundly impacted by it. But to Sean's point, when they go to care for a patient, it's not part of that dialogue. They are thinking, this is what I have to do to get this person well, here's the steps we'll take. So I think, you know, the obstacle is the incentivization likely won't happen through contracts. It's taken time just to get quality measures built into contracts, and that's probably the right priority. So I do think, though, that some simple dialogue and awareness that report offers would be like, if for those that are attending that are healthcare related, health insurance related, any of those things, I think there's opportunity there. From the rural perspective, I would say let's not forget about a resource right in front of us in most rural communities, which is our veteran services officers. They're a clearinghouse of information. They connect and make you aware of all these not-for-profits that might be around you, of possible interfaces, communities you can connect with. Something that goes beyond a VFW post, which is another common role. And that's not talking bad about a VFW post. They do a lot of things right? It's the sense of community that, and probably a starting point for so much of the work. It just incorporates alcohol, which is one of the things we're trying to battle at the same time. So I think those local resources that you can find in every county, a veteran services officer, can be a starting point for that interface that I was discussing.
No, thanks, Nathan. Thanks for highlighting veteran service officers, because I think you're spot on. You're exactly right. That is a tremendous resource that I think sometimes is underutilized. So, and Maggie, over to you.
Okay, so I think, I'm talking more about frontlines clinical practices. So when looking at that, I think it really is recruitment and retention in rural areas, in urban areas, as well as building out the infrastructure. That would be the primary thing. But secondarily is using these more unique healthcare workers to go directly to where the patients are. So I've had quite a bit of experience with community health workers. They do everything. They're very culturally competent. They can be trained across cultures. And they do a lot in terms of education, care plan adherence, advocacy, accompaniment, or just giving someone companionship and helping with case management and care coordination so that they make their appointments. When they're integrated well into an EMR, I will get alerts from them that a patient is missing a medication or needs a housing voucher form signed, so it becomes extremely seamless. So community health workers have been very helpful to me with veterans and all of my populations. Very similarly, community paramedics, which most rural counties have some type of EMT paramedic network associated with fire. So if those EMTs and paramedics can be trained in community paramedicine, they become an invaluable tool that can be deployed into any situation, whether urban or rural, and they go there. And what's really impressive about community paramedics is their level of clinical acumen. They're very much like a medic, right? So they have this a lot of clinical training. It can be overlaid with cultural competency and other parts of the community paramedicine training. And they also have diagnostic devices and medications right on their truck. It's just, it's full of tools. And so if they have the appropriate medical control, if they have a hospitalist or a really good family medicine doctor who's rural, who does everything from surgery to OB, or an ED doc, then they can really do a lot in the home for chronic disease management, post-hospitalization transitional care, for acute care. They can do prevention, they can do social determinants, but a lot of that has to, the barriers include regulatory. It includes finding the appropriate medical control, having CPT codes so these things can be billed. I mean, there are still lots of steps to take before we're there, but certification and training is really on its way for this type of medicine to take place. Now, when you take community health workers then and community paramedics and you wrap them in the technology to communicate with a team, including infectious disease, alcohol recovery coach, behavioral health, primary care, then I have had synchronous and asynchronous conversations with an entire team where everyone is on the same page within a minute on extraordinarily complex patients. I've had community health workers find patients under bridges in tents and bring them in to appointments, to surgical appointments, to behavioral health appointments, and alcohol counseling or substance use counseling, veteran and non-veteran. These tools are almost in all of our hands. We need to move these types of things forward on the front line.
No, thanks, Maggie. And I just wanted to go back because there was a point that Tempa made I want to make sure I highlighted, and that was Cohen Veterans Network. I can speak to the quality of the service they provide veterans and their families, because I have family members who are involved with Cohen Veterans Network, and we're very open and transparent about it here in the Whitehurst family when it comes to emotional and mental health. So I can tell you that is a resource that is really spot on in supporting veterans and their families. And I'm glad, Maggie, made the point about paramedics and EMTs, kind of looking at, when we talk about providers, again, we have this mental model of what a provider is. And I think part of increasing access is breaking that mental model and looking at, paramedics, EMTs, community health personnel, those in the community. I think that's a great resource to start to take a look at. So, well, this has been a great conversation. We're coming to the end, just a few minutes. Heather Flannery from Consensus Health will be giving some remarks, and we're all looking forward to that. But before we leave, I do want to give a chance to everyone to make any brief closing comments, and also give you the opportunity, if you would like, because Maggie brought this up to me yesterday, and I was kind of kicking myself for not thinking about this, but as we all know, we've seen recent events in Afghanistan, and there will be impacts to that among our veteran population. That may be one of the reasons I kind of forgot about it, because I'll be honest, for the last 3 weeks or so, I've really kind of put myself in a bubble trying to, we've talked about avoidance. I've been trying to avoid news about Afghanistan because I know for me, it's going to be a process of reconciling my service in Afghanistan to where we're at right now when it comes to Afghanistan. And I am concerned about how that will impact other veterans, their families, and also the families, of course, the families of our fallen. So I want to give everyone a chance to make any closing comments or remarks. And if you would like to make any, share your observations or anything in terms of kind of recent events in Afghanistan and how that may impact veteran health down the road. And I think I'll work backwards this time from the beginning, and I'll start with Tempa.
Thanks, Sam. It's just been an honor to be a part of this conversation, and it's so refreshing and confirming to hear so many similar things being said, and thought leaders across the country. We don't know each other, and we've come together, and we're all along the same lines, thinking in the same direction. And so I'm hoping those interfaces can happen, and that we can continue the conversation and take action. We need a call to action around these solutions. And from our family, concerning the recent events in Afghanistan, just like Colonel Sutherland said, there are no two veterans the same, no two military or veteran families the same. The perspectives on what has happened are also just as different. There are going to be unique perspectives on this issue, and to be open and empathic in how we interact with others, and don't be afraid to talk about it. But I think listening and letting people be heard and to feel what they feel and grieve this loss, as it's a time of grief for a lot of people, to reconcile their service, and all of those things matter.
Thank you, Tempa. Sean?
Yeah, Sam, I just want to thank you and Colonel Sutherland and the Dixon Center for continuing to lead in this space, convening subject matter experts, driving the conversation forward. This has been really rewarding for me to participate in this. I've learned a lot and look forward to moving all this forward with y'all.
No, great. Thanks, Sean. And get back on the road so you can get more providers to get involved in the program. So thank you. Okay, let's go over to Nathan.
Yeah, so thank you for including me. This has been great, and I hope it's of value for all those that are participating. So I think I would echo part of what Tempe had to say. Like I'm probably the panel member who is least engaged specifically with veterans and more around the periphery on this. And so it required a certain amount of education and interest on my part to dig in. And the work that the VA is doing around what they referred to as evidence synthesis. So identifying alternative care, such as acupuncture, yoga, meditation, mindfulness, and where the evidence supports providing this care so that a primary care physician can connect and be confident that they're actually prescribing something that they're not comfortable with, hasn't been in their forefront in the past. I think that's when we look at like what all of you are doing, what the VA is doing, that's brilliant work. That is work that will set us ahead light years for years to come. It's an enormous undertaking, but I think it's great work. So I just want to echo the idea that we're doing the right work. Regarding Afghanistan, my first thought is for those that were, immediately looking for reconciliation or validation of their service. It's too bad we all don't have a Colonel Sutherland in our pocket, because he certainly could make you feel like you knew why you were there. And just remind everybody of all of those little events that each of those individual veterans experienced, and where the value was in those will be their reward. And think big, think personally around that. And there's no doubt that when we, take on something with very broad, enormous objectives, that the detail of that work can get lost. But don't lose it on yourself, because you were an important detail of that work all along, regardless of the outcome.
No, thank you, Nathan. Very well said. Maggie?
Yes, thank you so much for asking this question. It reminds me of New York City. I was there during 9/11, and afterwards there was just a spike in mental health issues for 6 months to a year, and then it started to level off a little. My husband's family is extensively military, so I have some secondary knowledge, and of course with family members and talking to them. And they span from the World War I generation, who really, there are very few with us anymore, all the way to present day. And I would say that when you've dedicated your life to a mission and you have settled memories that you've worked out, whether or not you have PTSD, even if you don't have PTSD, and that mission was around freedom and democracy and honor and country, and even just taking orders and doing them well, and then that meaning is removed. It is not going to be unusual to see a spike in anxiety, depression, and even kind of a secondary, a remote form of PTSD, because you're reinterpreting memories, you're reinterpreting meaning, and for a lot of people, this is their life work. I have veterans who see me who may have only done a tour or served for a certain period of time, but they tell me stories every time they come to see me. And those are some of my most cherished memories, is hearing their stories, whether heartfelt stories or harrowing stories. It's things that I hold close, because that is the honor of being a physician, is being in the room with people in their most joyful and their most vulnerable state. Just as always, hats off to the veterans. Thank you for your service. And it was a real honor to be on this panel. Thank you.
Yeah, thank you, Maggie. And then Carrie, you can close us out.
Thank you so much, Sam, for for inviting me to participate in this panel, and thank you to the rest of the panelists. I too have learned a lot, and this has been a really wonderful experience. I'm grateful to be part of it. I guess one thing I take away that I really echo what Tempa said is that, and it also echoes what Colonel Sutherland said, is that veterans' experiences are very varied. And I think there is a tendency in the national discourse to have this idea of a broken veteran. And I think when we see imagery, and in fact, when we're looking for stock photos of veterans, it's often a veteran with his or her head in their hands, really looking down, like downtrodden, and that doesn't represent all veterans at all. And there are a lot of veterans who have had successful transitions. In fact, most veterans have successful transitions and have fulfilling lives. And I think we pay a lot of attention necessarily to those veterans who have more difficult transitions and need mental health care and other types of health care. But I think we have to also keep in mind, again, that there are a lot of different types of experiences and a lot of different paths post-service, and a lot of different experiences and feelings, and sort of thinking about that holistically, I think, is really important as we come out of these wars.
No, thanks, Carrie. I've run past my time, and so I know Sean is jumping in here right now, but I want to thank all of you for a really great and enlightening discussion and conversation. I really appreciate it. All of you guys have been great, and thank you very much for what you're doing to support veterans and their families, or really anyone who has any association with military. Really appreciate it. Thank you very much.
Thank you.
Okay, and as Heather begins getting her slides ready, I'm gonna reintroduce myself. I am Sean Mannion. I am the Chief Scientific Officer here at Consensus Health, and this is the Veterans Summit, the Veterans Health Summit 2 that we are co-hosting with Dixon Center for Military and Veteran Services. Earlier today, we heard from the founder of Dixon Center, Colonel David Sutherland, giving some opening remarks, and then we just heard a wonderful panel headed by Colonel Sam Whitehurst of the Dixon Center, with 5 providers and some of them veterans and some of them spouses of veterans, looking at veterans' health issues. And now we're gonna transition to a different look of taking some of the emerging technology that's available and how it can be focused on those problems, and some of the preliminary work that we've been doing with Dixon Center to do just that. And with that, I would like to introduce Consensus Health founder and CEO, Heather Flannery, not just my boss and colleague, but a friend of mine who has, since before the inception of Consensus Health, really focused on veterans issues. And one of our primary projects from the get-go was exactly that. And when she put it in front of me of January of 2020, it immediately reminded me of those elements of Colonel Sutherland's white paper on the Sea of Goodwill, and how you take this distributed will to do good for, in this case, the veteran community, and yet align that goodwill, those good actions, into something that matches the resource to need. And as soon as I saw her looking at the technical side of that same problem and the solution for that same problem, I said we need to meet. And so at the beginning of Consensus Health's inception on March 2nd, 2020, we sat down with Colonel Whitehurst and Colonel Sutherland and sort of outlined for them what some of these technologies could do. And from that was sort of born a new effort that we are getting ready to roll out much faster in the days and months ahead. So with that, Heather, please take it away.
I'll begin with my introduction while that's going on. My name is Heather Flannery. I'm the founder and chief executive officer at Consensus Health, and it is my profound honor to have partnered with the Dixon Center and to follow our esteemed speakers today is really a humbling experience indeed. I am incredibly excited to share with you an initiative that Consensus Health and the Dixon Center have been collaborating on for some time. And I hope that it leaves you inspired and ready to engage with us in our shared mission. This talk is about an initiative called Vici, and yes, it comes from Veni Vidi Vici. That is Veterans and Vulnerable Populations, Incentivized Coordination and Integration. Vici is a breakthrough model for increasing veteran access to privacy and dignity-preserving medical, emotional, and economic support. You'll notice both privacy and dignity are themes that Consensus Health and our partners at the Dixon Center value deeply, and we have some very unique opportunities to move forward in these areas. Next slide. So the first idea that I'd like to come up several orders of abstraction in how we're looking at the problem space and introduce an additional separate perspective about the macro pace of technological change. Throughout human history, our rate of technological advancement has driven our society at large, certainly including warfare. And in the past 50 years, approximately, we've had a massive explosion in the rate of technological change. In the last 5 to 10 years, that rate of technological change has continued to increase. And in very recent times, even in the last 2 to 3 years, we've seen extraordinary further acceleration of technological change. This is a wonderful thing, but the rate of change or adaptation of human systems and bureaucracies has not changed in any meaningful way, which means that our policy environment, our institutions, even our mental models, as we consider the art of the possible, are in fact now simply not yet aware of what is newly possible. Further, we have a tendency to radically underestimate both the risks and the opportunities that are created by radical technological advancement. And today, in September 2021, as we sit here, at this event, we have available to us extremely powerful, very new technologies that enable capabilities that sound like science fiction, but they're not. Next slide, please. So what if it were newly possible, only recently possible, for us to integrate, optimize, and automate processes that spanned many organizations, governmental, philanthropic, the private sector, and do so in a way that individualizes instead of homogenizes multi-sector support for veterans and their families? I will argue that we are in fact now living within this technological possibility that in the very recent past would have been completely logistically impossible and untenable. We now have this opportunity before us. What if it were newly possible for veterans and their families to be empowered by the ongoing analytical use of their aggregated, validated, and comprehensive health information and health relevant information, but without any compromise to their privacy? Our entire worldview involves data exchange, data centralization as a first principle for activating all kinds of resources and possibilities. But today, we no longer have to make the trade between privacy and security, between privacy and being activated into programs and resources. What if it were newly possible to match and integrate a unique set of veteran support services for each veteran across an ever-growing number of programs, such as those that the Dixon Center so ably leads and coordinates? What if new systems of multi-stakeholder incentives could much better activate the sea of goodwill that we have in the United States of America and globally? These are the questions that to which the Vici initiative is the answer. And Consensus Health and the Dixon Center and our other partners and allies have been hard at work for some time determining how it is that we can bring to bear these new technologies and these new possibilities as rapidly as possible for the benefit of veterans and their families and other vulnerable populations. Next slide, please. So why is now the time that Vici could succeed? Earlier, I mentioned that the rate of change of human institutions and cultures is not nearly as rapid as the rate of change of new technologies. Also, we tend to normalize and surrender to some of our most chronic systemic challenges in the healthcare industry. In the face of impossibility, we draw back our expectations in the interest of realism. Well, now we have not only the capabilities, but we believe our hypothesis is that we are at an inflection point where the timing culturally is paired with the readiness technologically. Our COVID-19 crisis has exposed serious flaws in the current health system, but all of us here gathered today, all of our esteemed speakers are deeply, deeply familiar with these long-standing systemic flaws in our health system. What has happened, a silver lining in the tragedy of the COVID-19 pandemic, is that the general public has become aware in a way that they were not before about the problem of data silos in healthcare and the way that it affects our ability to do things that seemed like they should be so straightforward and intuitive, like testing, like vaccination, and so on. This is paired with the technology readiness of a new generation of paradigm shifting technologies. I know this is not a technical audience, so the details of these technologies is not the key takeaway of what I'm hoping to convey to you. But what I would like to convey is that the order of magnitude and significance of these next technologies are on the order of the Gutenberg printing press, the integrated circuit. These technological innovations are massive and paradigm shifting in their impact, and they have reached a level of maturity and readiness that coincides with a cultural tipping point and a macroscopic readiness for change. One of the core technologies that is at the heart of this is called blockchain. Many of you may have heard of the blockchain. You may have never heard of blockchain. You've almost certainly heard of Bitcoin. And Bitcoin is the underlying, blockchain is the underlying technological innovation that is a new infrastructure for trust. And it also has an application of currencies, which enabled Bitcoin as the first example of that. But the underlying technology is far more fundamental to the transformation of human societies, we hope in a positive direction, than the cryptocurrency first application of it that you may have become familiar with. We're not going to go into a deep dive explainer on blockchain technology, but critically, it is a technology that facilitates automation and orchestration across organizational boundaries, across entities, up and down a value chain, throughout an ecosystem. It also is a technology that can facilitate radical individualization. In healthcare and life sciences, that means taking precision medicine to its culmination point. It means implementing a learning health system in a way that realizes the vision and intent of that movement, and ultimately takes individualization far beyond just our biomarkers and our biological physical bodies into the totality of our social determinants, our community, our lived experiences, and the other aspects of our life that have been so richly described throughout the day. Next slide, please. So just defining what, back one, please. Defining what blockchain is, just at a fundamental level, it is a distributed ledger, which is really a kind of database. it records transactions in a way that is immutable, that is tamper resistant, and that enables parties that do not trust one another, who have potentially even potentially adversarial relationships or competing interests. For example, I'm concerned about the privacy of my data, and I may have a medical condition like clinical depression that I don't want everyone to know about, but I still need to access care. Blockchain is an unusual technology in that it facilitates both the ability of a guarantee of identity, and it facilitates the ability of a guarantee of anonymity. It's really a counterintuitive thing to imagine a technology equally well suited to achieve both things, and to enable an individual to disclose or not disclose in granular ways information about themselves, and to control digital assets and data in a very granular way about themselves. Next slide, please. So in healthcare and the life sciences, the use of blockchain is actually quite a bit further along than is generally understood. When people hear about this technology, there is a lack of understanding that the technology itself is long since validated. Now, whether the use of the technology in healthcare or life sciences moves population health endpoints that we all care about, that's not yet validated. But at a technological level, we're no longer in the phase where what we need to do is validate whether this technology works. We know it does. One of the surprising things is to see how widely across our industry major blockchain initiatives have gotten underway, and gotten underway years ago at this point. So when we're sitting here in 2021, this actually isn't new at all, and these organizations and more, most governments around the world, including our own in the United States of America, pharmaceutical companies, payers, providers, many parties have been heavily invested in and recognized the value, the potential value of blockchain technologies, years ago at this point. And in Consensus Health's partnership with the Dixon Center and what we're seeking to do with the Vici initiative, we are creating another such consortia like you see here that will bring about in our vision, in our hope, a completely next generation approach to how we tackle some of our stickiest problems. Next slide, please. So when we think about blockchain, there are multiple blockchain technologies. Just so that you understand who Consensus Health is, we really come out of what's called the Ethereum ecosystem. Ethereum is an absolutely revolutionary global innovation. It has no owners and no jurisdiction, and it could be thought of as the beginning of the new internet. It is not owned by anyone. It is a neutral public resource. And the origin of blockchain as a technology began with the first Bitcoin that was ever mined in 2009, and Ethereum is the next generation of blockchain that was introduced to the world in 2014. The term Ethereum carries 3 distinct meanings. You can fill out the animation on this slide, but don't move to the next slide. So Ethereum is a protocol that is completely open source, free to the world to use. Keep going, please. It is also a network. There is the Ethereum mainnet that is a living, distributed, what's called the world computer, that is available for all of humanity to use and to connect to and to benefit from. And it is lastly a cryptocurrency like Bitcoin that is the native crypto asset to this protocol called ETH or Ether or Ethereum. Go ahead. The Mr. Joseph Lubin on the right is the founder of the organization called Consensus. Consensus Health is a spin-off of Consensus, seeking to bring this technology with some others into the healthcare and life sciences space to drive what we believe will be great good for humanity. Let's move to the next slide. Our perspective is that for healthcare and life sciences, blockchain is incredibly important. It's absolutely necessary, but it is not sufficient. So there are two other families of technologies that Consensus Health is integrating into blockchain that underscore or underpin what the Vici initiative can do and will do for veterans and their families. Those are on the left-hand side, you see a royal blue set of boxes. Those are all the aspects of blockchain. The networks themselves, something called smart contracts, which is an automation technology, tokenized assets, which is an optional way of using the technology, and then finally applications that run within blockchain networks. That's all what exists when we say blockchain. But in healthcare and life sciences, we have 5 areas of major challenges that are extremely unique to our industry. And those are cybersecurity, compliance, identity, bioethics, and privacy. And the combination of blockchain technology with the 2 other buckets that underpin Vici is what we believe will make these things possible. And it's really in the convergence of these things that these radical new possibilities are created. Privacy in depth represents a bucket of brand new technologies that all have to do with either hardware dependent or software dependent advanced privacy preservation methods. The key idea to take away there is think empowerment of the individual and think granularity about the allowed use of data. Also, moving away from the notion that data has to be exchanged in order to be used. It can be analytically activated without being moved from its point of origin. That, in and of itself, is a radical enabler and empowerment of individuals that through the Vici initiative we can create. Decentralized artificial intelligence is the 3rd emerging family of technologies. And when we think about sovereignty and self-sovereignty and agency and dignity and what it means to live in a massively technological society, well, our data is our labor. Our data is our identity. Our data is our human potential to have our diseases cured and our suffering addressed. Our data is significant in a way that we have failed to elevate to the appropriate level because it has existed in silos. And if our data is spread in this wide diaspora of institutions everywhere, we cannot actually create value from it. So even though it belongs to us in some legal framework, changing jurisdiction by jurisdiction, we can't create value from it. Well, governments and corporations can use artificial intelligence to achieve their aims, but individuals cannot. Those resources are completely outside the reach of individuals. But our vision is that ultimately artificial intelligences will also become self-sovereign. And we want to see veterans and vulnerable populations be the first that receive access to this incredibly empowering new technology instead of segments of the population that are overlooked or deprioritized. Next slide, please. So you hear about data constantly, you think about data constantly. We'd like to offer a new semantic structure for talking about data because it ceases to become meaningful in discourse in the way that we use it today. We talk about source data as at its point of origin, as it's being created. You could think of us going through our lives and leaving a continuous trail of data everywhere we go, from social media to our healthcare interactions to our banking and financial relationships. Everything we do in this massively technological society generally leaves some kind of data trail that exists institutionally and individually in massive and exponentially increasing scale. Metadata is all the information about that information. It's what we need to know to be able to even understand what kinds of questions we could answer with that data. And then finally, the derived data is the actual value that we're after. It's an analytical result or finding that is the point, the reason why we would want access to source data in the first place, as described by its metadata. In this framework, we will be tackling self-sovereign veteran health and health relevant information as source data, abstracting metadata, and creating extremely high value derived data for the veteran, by the veteran, under the veteran's control. This message of empowerment and dignity and agency and sovereignty is incredibly important to the Vici initiative. Presently, in the way the world works right now, if you want to create value out of data, you have to first exchange it somewhere and centralize it. We believe that we've reached the logical extreme of that approach, and now through the use of these new technologies, we can use radical data decentralization to create value on behalf of individuals without that data having to be shared or exchanged in order to be used. Next slide, please. So just spending a quick moment here, we live today with respect to the way that veteran and their families' health and health relevant information is generated, used, governed, custodied in what we believe to be a sunsetting paradigm. We are in the last final chapters of a dysfunctional technological paradigm that created a lot of value and also left many, many things far behind that were important to us as a civilization. That sunsetting paradigm always meant that we had to copy infinitely and move data everywhere in order to create value from it. Consensus Health, with our partners like the Dixon Center through initiatives like Vici, we are helping to drive the emerging paradigm where we are able to create value from information without having first moved it or centralized it, while preserving the privacy, the dignity, assuring the identity, verifying the compliance, and securing from a cybersecurity perspective the infrastructures and the data that move through these new systems. We have, next slide, we have reached the logistic extreme of data centralization strategies, and just a quick point I want to make is that every human being in this massively technological society is going to create over 1,100 terabytes of data about themselves that all can be used analytically to benefit the individual, if the individual can be empowered to use that. And that is what the Vici initiative it purports to do and will intend to do for veterans and vulnerable people. Let's move to the next slide. So you can go ahead and build this slide out. So right now, our health information is siloed. Trying to inspire institutions, corporations, please send us your data. Your data here, because I'm one of 10,000 ever-growing organizations that wish to centralize it so that I can provide some kind of analytical value. That's the heart of it. Well, our proposition is that instead of going, instead of just making bigger silos with blockchain networks, we have to connect those networks so that we're finally killing the data silo, not just making bigger ones. The way to accomplish that comes back to what I was telling you earlier about the neutral, open, public resource that is the Ethereum mainnet as the mechanism by which private blockchain networks can all be made to bridge and interoperate with one another. This is how these smaller blockchain networks can create value without making bigger and bigger and bigger data silos. Next slide, please. So this is the last slide in my presentation, and it's an eye chart. So wanted to ask your forgiveness in advance. But this is a conceptual overview. Now that you have the broad framing of what Vici is, why we're doing it, this is a conceptual overview of the scope of what this new infrastructure, this new model that we are creating can deliver to veterans and their families. There are the foundation of all of it is the concept of enterprise blockchain blended with advanced privacy preservation and decentralized artificial intelligence that's delivered through Consensus Health's core innovation, which is the elevated compute platform, and the use of the neutral public resource, the Ethereum mainnet. This delivers the ability to apply in real time and optimize intentional bioethical principles to the use of to how this new technology affects veterans and their families. It creates the ability to provide cryptographically verifiable guarantees of privacy, and to make that privacy highly granular, time-bound, this specific data for this purpose, for this period of time, etc. And to make that data sovereign to the data subject, the veteran and their families in this case. The underlying infrastructure here has a radically enhanced cybersecurity posture by comparison to baseline infrastructures as they exist today. This is at a fundamental level. I also am acknowledging that these new classes of infrastructure introduces new classes of cybersecurity risk, and mitigating those and controlling for cybersecurity is massively important. We view new infrastructures, new utilities like Vici as critical infrastructure, next generation critical infrastructure, and it needs to be secured and defended as such. This technology facilitates the creation of decentralized identities, which can include identities of institutions, of objects, of medical devices, of automobiles, of anything that you can imagine. But importantly, it can include identities of human beings, and those human beings can take control of their identity in what's called a self-sovereign identity. And this ability to control that identity, how it is connected to pieces of data and engagement in processes is fundamental to the ability to achieve Vici's vision. And then lastly, healthcare compliance, as you all know, is certainly substantially more complex with veterans and their families and military. It's already massively complex for the general population. We need to be able to programmatically design compliant processes and provide proof of same without massive bureaucratic burden in order to achieve compliance. So much like we feel that our next generation of technology is intrinsically superior from a cybersecurity perspective, so too does it facilitate a less burdensome achievement of compliance, and move past just to the letter of the law compliance into the spirit of the law with the achievement of bioethically intentional and privacy preserving modalities. So that's at the foundation of Vici. There's both a user experience and a technological design. We're not here to get into the weeds about the technology, but rather to focus on the art of the possible that Vici can achieve. There will be, for the veteran, starting over in the yellow box, self-sovereign data lakes that have intelligent automation that is targeted for and by that individual intrinsic to it. So this means that veterans will have a place that is secure and trusted where they can aggregate big data about themselves. This is a data lake where n equals 1. Where the data subject is able to aggregate, curate, and ultimately monetize for value, if appropriate, all of the data about themselves that is generated in n number of institutions. And this is facilitated in the United States by the enforcement window coming into effect for the 21st Century Cures Act. So out in community care, outside of the VA and outside of military medicine, every citizen of the United States now has a right under the 21st Century Cures Act to receive their health information. Now, the infrastructures to facilitate this, what a person is supposed to do with this information, where they're supposed to put it when they receive it, and critically, how it is supposed to be aggregated and curated, those are unsolved problems that we feel Vici will absolutely solve for veterans and their families. But we are already in a regulatory and a policy environment that supports self-sovereignty and is trying to finally cure the data silo problems that we've had since the digitization of medicine and the implementation of meaningful use in EHRs and how that went down in the United States. The ability over on the far right, tokenization and funding functionality, This allows us to bring all of fintech and finance and payments into the simplification of things like claims, where multiple payers perhaps have accountability across different episodes of care or different disease states or conditions or circumstances. This allows us to facilitate the pooling and aggregation of resources that might come from multiple sectors into a unique veteran-specific assemblage of resources from within the sea of goodwill. The ability to provide financial resources across multiple modalities and connect to non-financial critical resources like emotional support, like healthcare delivery, like transportation, etc. These things are facilitated by the transactional economics enabled by blockchain. And then finally, from a user experience perspective, veterans and their families will have the ability to make empowered choices by seeing how the different resources that they might want to access are sourced and priced. They will be able to have self-sovereign software that assists them with the coordination across many and perhaps an increasing number of programs, using their data and their information to affect their will and manifest their well-being and prosperity. It does not change the fact that all of the institutions that originate that data, they too own their copy that they originate, that they must govern, and then they custody. But the individual now, the individual veteran and their family, under the law and given the new technologies and infrastructures created by Vici, can be radically empowered in a way that no individual institution ever could on behalf of a given veteran. So I'm gonna stop there. I believe there's one last slide just as closing remarks. So I wanted to emphasize something that I heard Colonel Sutherland talk about multiple times. When you've met one veteran, you've met one veteran. For me personally, I've met veterans that were each of my grandfathers, multiple uncles, my brother-in-law, many dear friends, and everyone is unique and everyone served. And I cannot thank all veterans enough for their service to the United States. And this opportunity to work with the Dixon Center to bring the most radical emerging technologies to this most deserving population in a way that supports uniqueness and individualization instead of homogenization is such a rewarding endeavor to me, and such an honor on behalf of everyone at Consensus Health to be engaged in this mission.
Dr. Vigilance is our Vice President of Social Impact and Population Health, and his interest in social determinants of health really spans not only the veteran population, but really all people, but in focusing on those underserved populations, it's an element beyond electronic health records, beyond the biological, that has a impact on health that is just starting to be realized.
So before I get into introducing our illustrious panel, I wanted to sort of do a quick recap from this morning, because I think there were some really sage comments made, and we definitely want to dive into this conversation with these folks who have joined us today. And so Colonel Sutherland this morning highlighted a couple of different things. In that Sea of Goodwill document, he talked specifically about the fact that this trifecta of education and training, care and wellness itself, as well as employment, were essential to family wellness, if you will. And so that was a great introduction to this notion of social determinants of health, which obviously go beyond those three things, but are very important. He said, when you've met one veteran, you've met one veteran. And so it's important to recognize that every one of these veterans has different needs. And I think that that's also something that should be taken into consideration as we talk about vulnerable populations just in general, and that cookie cutter solutions, as you referred to, do not work. Care needs to be more precise to enhance outreach, program design, human interaction, and embrace the unique identity of each individual. And the third thing he said that I thought was particularly poignant was we have to solve the epidemic of disconnection. And that's another huge piece of this social determinants conversation. Dr. Allard, CEO and founder of the Community Health Design Institute, talked about housing and the mental health and substance abuse impacts associated with that, but how that again impacts a number of other factors related to care adherence, nutrition, etc. Nathan Ludke, a public health professional, community health professional who's been in the local and state government levels of public health, talked about healthcare being complex at a baseline, and the community-based solutions are what make the difference. And then Dr. Whitehurst came back to that conversation about navigation for veterans being something that was very easy for them with their healthcare while in the service, but once they get out of the service, it becomes a bit more of a challenge. And so we have this opportunity at the moment, especially with, and we'll talk a little bit about this, the American Recovery Plan, to do a few different things. One of them, catalyze health equity initiatives. Another one, modernize public health infrastructure via data modernization, which can mean a number of different things. Another one, which will be huge, is to build public trust, particularly in our public health systems. And another piece, which I wanted to use as a segue into this panel, is innovation starting with better communication. And I think that it's really, I feel very fortunate to be associated with all three of these individuals. I'm going to make some brief introductions of each of them so that you can get to know them, and then I'll let them each give a couple-minute sort of opening set of remarks related to social determinants and leveraging technology to address them. The first person I'd like to introduce is Matthew Goudreau. Matt Goudreau is the Vice President of Operations at Activate Care, which is a Boston-based social determinants of health collaboration and referral management software. Matthew has a public health degree in emergency management and held a National Registry Paramedic certification for almost 25 years. He's internationally recognized in the field of mobile integrated health and community paramedicine, something you heard Dr. Allard refer to earlier on, which has afforded him the opportunity to be published multiple times and is represented internationally on the subject. He has a leading role in designing, implementing, and operating cutting-edge care delivery models that think outside the established methodology. So thank you for joining us, Matthew. Joining us is Joshua Prasad. He is focused on health equity as the Director for Health Equity Innovation. And he is focused on health equity through public health innovation and community. He is with HHS, Health and Human Services, and prior to joining Health and Human Services in 2020, he worked at Deloitte Government and Public Services Consulting, where he led projects in the social determinants, health equity, and COVID-19 related disparities until early 2019. He was Center Director of a rural health center and has focused on national initiatives like Public Health 3.0, the first federal framework on social determinants that aims to re-envision public health at the center of communities. He completed an innovation fellowship at Harvard Center for Primary Care in 2016, has a master's in public health from Drexel University up here in Philadelphia, and his bachelor's from Rutgers. He's currently in the DRPH program at NYU in their inaugural class of 2021. So thank you for joining us, Josh. And last but not least, Dr. Barry Lewis is a population health executive from Absolute Total Care, which is a Centene health plan. As the Chief Medical Officer, he has oversight for the quality of care administered for a Medicare, Medicaid, and health exchange population. He applies a collaborative approach to uniting healthcare stakeholders to achieve exceptional clinical outcomes. He is driven by a national charge to expand access to care, improve care experience, and enhance accountable utilization. He thrives on being a community steward for well-being objectives. He has his undergraduate degree from Vanderbilt University with a BA in mathematics, and received his medical degree from the University of Tennessee in Memphis. His residency trained at Johns Hopkins Hospital, and later achieved his Master's of Business Administration at the University of Tennessee. So thank you, Dr. Lewis, for joining us. if I could ask each of you to take a couple minutes before we get into our sort of more round robin conversational style of this afternoon. If you would, we talked a lot about this being a social determinants conversation. Social determinants were outlined earlier on. I mentioned a few things just now about some of the comments made about what's peculiar to or particular to some of the veteran-related issues, which I think also apply to vulnerable populations in general. Your take on sort of your comments on opening remarks related to social determinants, achieving health equity and what that means or looks like for vulnerable populations, and how we might leverage technology and or data to better be able to get to that. So your opening remarks with respect to that, a couple of minutes each would be great, and then we can get into our conversation. If I could start with you, Dr. Lewis, would that be good?
Absolutely. Hopefully you can hear me well now. Are you able to? All right, good. Appreciate the opportunity to be able to speak to everyone here. And I will start off like this. I remember being in medical school, first, second year. We got this huge textbook about 5 inches. It seems like it's 5, 6 inches deep, and Robbins pathology. And you're supposed to know everything in Robbins for the next test that was coming up in 1 month. You only had about a couple weeks to prepare. In that textbook, it went over all these medical conditions. In those conditions, it would say your risk for them. It would give you your mortality, likelihood of surviving, and it was there, up and open, shut, closed, that's it. In that evaluation of a particular condition, it might tell you that based on your racial background, ethnic background, you have a greater likelihood of this. And that's it. That's all you had. You had no way to get around it. You had a diagnosis, you had a lifespan that you expected to have, and that was about it. And it was greatly a disadvantage for people of color from looking at some of that information. Well, I'll fast forward many years into my practice and getting to the health plan side. So as a chief medical officer of health plan, lots of information comes in. You've got all the information about encounters, whether it's inpatient, outpatient, and this is going into different databases. And then all of a sudden we had our care managers, and we talked about the outreach in the program today, but the care managers were expected to do certain things. And then when I looked at some of the programs, they were pretty simple. It was identify certain conditions, understand what's going on in the person's home or in their own environment, what's keeping them from doing what they need to do to take care of themselves, what's preventing them from taking their medications. And if you could do that, there is a greater chance that you can improve their outcome. So what I took from those two experiences that I'm sharing with you is that it isn't an open and shut case. It's really significantly about social determinants of health. They come up with some of the numbers, and social determinants of health represents about 5 different categories, whether it's where you live, your environment, your education, what access you have to hospitals and care. And then they say 20% of it is what that doctor tells you what to do. That leaves about 80% of something else that has to be managed. And that's what I learned to be so effective in the environment that I've been in the managed care setting, working on the health plan side. Doesn't take a rocket scientist, someone with a super advanced degree. It takes someone who's compassionate, knowledgeable, who is really committed to influencing the well-being of another individual. And that is all mitigated by or advanced by the information that's shared in our data platforms that are coming in. We have, as I mentioned, we have information coming from so many different directions. And so putting those all together, social determinants of health means a lot to me personally, for the well-being of other individuals. We actually have access to various populations. We have a commercial plan, Medicare, Medicaid exchange. So some of the most vulnerable populations. And for me, that transfers over to about any population across the world. So that's a little bit of my intro. Thank you very much.
And thank you, Dr. Lewis, for that great intro to try and follow. And thank you to everyone here for having all of us. It's really inspiring to hear some of the work that others are doing and the real impact we're trying to I think, talk about and hopefully really deliver too, from all our different perspectives. I think I also have a pretty personal connection to social determinants. I spent most of my career working in this space to try and advance it from where we have been to where we're hopefully going. And that's why I actually joined the department earlier this year to try and take an opportunity and accelerate it. And I think that's what we do here in the innovation team at HHS. So I'm the Director of Health Equity Innovation here, and a big focus of that is on the social determinants. I'll say that having worked sort of at the federal level, federal national level, I've worked in the health tech space and worked on the ground in a variety of different capacities. Something keeps popping up every time, and it's the need for more connectivity between sectors and really elevating the ability of local communities as the place where people live, work, play, and pray, to be able to be a place that people can live in and be resilient and not just survive but thrive. So I think that with that in mind, that's largely the focus that I bring to the social determinants conversation. Like Dr. Lewis mentioned before, we know that some 80% of our health is determined outside of our clinical interactions, and so it is our impetus to think outside of the box, or outside of the clinic, as it were, to really designing what communities look like and where people do everything else except their clinical interactions. Some of that I think has been addressed or starting to be addressed through the referral systems that are sweeping the nation, as it were, and the social determinants conversation. But we also need those to work hand in hand with rebuilding community. The pandemic has really opened up that opportunity for us to actually not just address COVID-19, but address the factors that are causing disproportionate cases of COVID-19. A lot of those are happening in BIPOC populations and other vulnerable populations. And so as we address the community needs that they have there, hopefully, I think part of my vision anyway here at the department is to make sure that we are thinking not just for the pandemic right now, but preventing future pandemics. And really a lot of that is about how we can actually build communities to be resilient towards all other sort of health maladies. I'll just finally note that I'm really excited to dive into these conversations further, and the note about veterans as just one population is really important. When we think about social determinants, or when I think about social determinants, it's oftentimes why is this not more focused on Black populations or Indigenous populations or veterans? And I think that's one of the unique things that we can think about from an equity perspective here. Health equity really can be for all, and if we're redesigning community-based systems, that can impact and affect everyone who lives in those communities, whether those are physical geographical zip codes that people live in or other types of communities that we have. And so veterans, I think, very much fit, veterans and people who serve in the military very much fit into that conversation, and I'm eager to make sure that they're included in that conversation as well too. So thank you.
Great. I'm really excited to have the opportunity to present here. You know, Pierre had mentioned I have 30-year experience as a paramedic, and one of the interesting things about coming into the social determinant space from a paramedic background is that we went into people's homes, and our care started where they live in their world, and we really exposes you know, the EMS professionals and fire and police, all of us, to a different level of understanding, or worse, not understanding how we got to this place in this individual's lives, and feeling very helpless and being able to help them move to a different and better place. So we were reactionary. We were dealing with something in the moment and helping them in that particular instance, but could see the other things that were going on around them and didn't really have good avenues to help them. And about 10 years ago, I was lucky enough to work with a really amazing group up here in Boston, Commonwealth Care Alliance, to build a community paramedic program where we took our paramedics and we used them as a kind of an alternative care delivery system where we know these patients, we know the world that they're in, they trust us, we walk through the doors paramedics and they can relate to us immediately. And we were helping them in very different, unique ways. It was a really empowering experience, and it really opened my eyes to the things that were capable of being done and how we can take traditional healthcare delivery systems and use them in totally different ways to really have a more impactful, you know, overall care delivery model. And so that it was great. I loved it, and I did it for a long time. And then one day I woke up and said, I don't want to be the community paramedic guy. As a traveling around the world presenting at conferences, and I really wanted to do more. And so I was really lucky enough to come to Activate Care and be able to participate in a software system that was working at the heart of trying to tie together care in the social determinant space. A couple of things that really stood out to me when I looked at this opportunity was that their goal is to bring all the players together. And I heard Colonel Sunderland say earlier that it's a whole community approach, and that's really what we're all about. We're trying to pull together healthcare and behavioral health and the CBOs that are working in the local space and community health workers and various entities to bring them together into a singular space so that we're treating the individual as an entire individual. One thing that really stood out to me in listening to various stories and conversations today is that we sometimes forget that because we've fractionalized our care delivery systems and we have those data silos as well as care delivery silos, that people of traumatic backgrounds unfortunately have to commonly relive their traumatic experience by retelling their stories over and over and over again in various settings. And every time they interact with the system, it's a painful experience for them because they're retelling something that they've told far too many times already in our system. And it's part of the underlying reality of mistrust in our system and why they don't want to seek out care and why they're hesitant to go back into it because we're reopening those wounds and reopening that trauma. And out of that comes part of what we stem from, which is trying to get everything in a singular place, that we're looking at the individual as an entirety. You know, we use the term whole person care because we've done a ton of work in the state of California with the programs that are out there and understanding how they're wrapping these patients with various levels of care into a singular platform and getting all the information, full visibility in a singular space where more people can interact and play a role and see everything that's going on, and really reminding ourselves that these people in vulnerable populations, there's a lot more to them than just the individual piece that we're treating as an individual provider, but really looking at them in the entirety. And so that's really where Activate Care comes from. We believe that health equity needs to stem from that level of getting everybody on the same page and have everyone participating in a singular kind of mindset moving forward. One of the other things that I've learned recently is I've really been thinking a lot about, we have this amazing opportunity right now in social determinants of health that we have not had ever in the time that I've been looking at this in the past decade. And that is that there's funding. And that's something we haven't seen. And that funding means a lot because now we can start thinking about doing things differently than we've done them in the past. And I think that that's going to be really, it's an amazing opportunity, and it's a really great time to be in the space and really exciting time to try to work with various groups to talk about social determinants and how we address it. Foundationally, I think that one of the biggest things that we have to overcome is the fact that social determinants is part of a healthcare system, but it doesn't necessarily need to be embedded within the healthcare system. And I think there's a potential to move it to work alongside of a healthcare system in a way that allows these CBOs and allows these boots on the ground people to be doing this work and sharing information and sharing visibility into what's going on, but doing it not necessarily within the healthcare system. And I think that that's part of what we're trying to start to dig into, and using a collaboration tool where we can bring in the healthcare component, we can bring in the payer component if necessary, we can bring in the CBOs that are doing the work and put them into a singular space and give them a place where they can do this work. And so it's a really great time to be in the space. There's a lot of work to be done. Foundationally, we have to figure out not just how to treat this problem, but can we treat this problem? And what I mean by that is there is nowhere near enough resources to meet the need in the social determinant space. And we really need to dig deeper as a society into where are our existing resources, what are the capacity of those resources, and where are the gaps? And I think the gaps are far more substantial than we're aware of right now. And hopefully part of this initial phase of coming out of funding this is that we can get to the heart of the matter of understanding, you know, we talk about food deserts, we talk about healthcare deserts, but it goes way beyond that. And understanding, okay, it's great that we have 5 food pantries in this area, but each one can only handle 100 people, and there are 5,000 people with needs. And we have to get to that level of detail from a population health perspective to really be able to address this issue, because we can build all the software systems we want, we can build all the pathways we want, but if we don't have the resources and the communities to meet the need, we're never going to meet the need.
The first question that I want to throw out to you it's sort of, you know, social determinants of health is having a moment. And I think that it's always kind of interesting to me, as Dr. Lewis was thinking about or talking about medical school, which I won't say how many years ago that was for him. And it was a decent amount of time ago for me, but so social determinants of health are not new, I guess is the thing. And so there's nothing really new about this notion that health is much more than health care. But it's having a moment, and I think that it's maybe fair to say, and this might be a bit, it's inflammatory, but you know, we're looking at the privatization of social services is probably something that is imminent, and a number of things that go along with that mean that we've got to be addressing social determinants far more aggressively than we have been if we're going to be impacting cost and if we're going to be impacting outcomes. So as you look at this space with respect to the number of people who need to be engaged, I think of Tom Cruise in that movie Minority Report and all these dots that have to be connected in order for them to solve the crime. There are lots of sources for places that need to be engaged. Where do you see from a public-private partnership opportunity, and this I think applies to all of you, because even if whatever space you're in, the opportunities to be public-private partners is sort of there. What sort of excites you most about what that looks like going forward? So if you're on the private side, how would you like to be partnering potentially with municipalities? If you're on the government side, what do you see, Josh, as the potential opportunities for partnering with the private folks? So I'm going to start off with you, Josh, from the government side of things, if you don't mind, and then we'll go from there. But what sort of excites you about the promise held by public-private partnerships and other collaborations to address SDOH?
Yeah, no, I think it's a key point you're hitting on. And so it's definitely, I think the word you use is moment. We're having a moment in social determinants. Matt, you mentioned it before too. And I'll actually just start by saying, there was like 6 years ago, I tried to found a social determinants-based startup, and it was really hard to get funding for it, a little bit. And in the time since then, it seems like not only is there venture capital funding for more health tech stuff, but their funding is really flowing in such a unique new way to try and address these really critical different problems. And Pierre, you mentioned before, I was part of a framework development here at HHS called Public Health 3.0. That was, I think, 2015, 2016. That was one of many indicators out there that we're trying to change the conversation around social determinants. So I think in that time, we've seen a massive market shift, if we will, moving toward these upstream factors, and it's brought in key thought leaders and resources and innovations to the space that I think we should be really happy to see, which is great. The promise, I think, of public-private partnerships is a pretty critical one, because especially from my perspective in coming in government, but also working in communities, like I said before, there are largely many problems that can't be solved just solely by the free market, the private companies that go out there. Y'all in the private sector have bottom lines to meet, and it's really hard to justify solving homelessness or solving a food desert just because of the goodwill of your corporate hearts. And so I think there are needs there. And similarly, we in the federal government, certainly, and in other parts of other types of government too, do not have the speed and agility and ability to bring in the best experts or problem solvers to solve those problems in the timely way that it needs to be. And so I think that's really where the opportunity for public-private partnerships can really be a good one. I think you mentioned something about how does technology factor into that, and I want to just address also, as someone who's played in the health tech space too, that especially when it comes to social determinants, and I personally see a need for permanent, sustainable SDOH change, and that doesn't necessarily mean technology is baked in there, or it starts with a technological solution, but I think it can benefit from technology. When we're talking about solving homelessness or food insecurity or these other major social determinant areas, I think that starts with how do we get a roof over someone's head? How do we get someone eating a meal today and long term? And if there's a tech way to do that, that's great. And so I personally just looked at a lot of the conversation around social determinants, health equity, et cetera. And maybe this comes with too much cynicism, but selling the app, selling the UX, selling the IPO numbers for health tech, that's great. Those aren't the things we should be tracking. We should be tracking how we're actually scaling improvement and really delivering impact. And that's part of the conversation I think we need to get to as well. And so I'm really excited at the opportunity, knowing that I personally work in an innovation shop in a very slow and old organization. It's hard for us to, build things, but we need to. That's why I think public-private partners really work. And so that'll be one thing I'll note is that I'm on the HHS innovation team, which is actually a rebrand of our old Chief Technology Officer's office, which you all might be familiar with from some of the work we might have done in that capacity. But the rebrand, I think, is actually pretty critical because innovation, specifically public health innovation, in the moment we're in now, requires not just technology solutions. It really requires rethinking systems, some of which are grounded in technology and some of which are, how do we redesign something more holistically? And maybe there's tech involved and maybe there's something else. And so all of that is to say, I think we can't do it alone in government. We're looking to our key partners in the private sector to help work with us, and we have the reach, we have the impact, we have the ability to scale. We just need the tools and the brain power to help do it.
So given that, and thank you for that, Josh. I have the suspicion, and Matt, you could tell me if I'm wrong about this, that from a nimbleness perspective, that you have some greater nimbleness than Josh might have with respect to speed of building and getting things out there. I could be wrong in that, though. I think there's this perception that when you do things as a startup and you do things in the private sector, that everything moves so much quicker and smoother, but we know that that's not necessarily true. From your perspective and thinking about this public-private partnership opportunities, Activate Care, how have you looked to leverage those government relationships to be able to make what you offer of value to the clients that you're serving?
Yeah, it's great. It's a great question, and it's true. I mean, I agree with everything Josh is saying. That this really there's a place for technology. There's a place for policy change. There's a great place for a lot of these aspects that all need to fit together. And some of them are going to come from the private sector, and some of them have to come from the public sector. And but I think that one of the foundational key elements for all this, for me, is outcomes data. We don't have good outcomes data, and I work in the field, and I work in the technology that's trying to drive outcomes data. And what we hear consistently from state agencies, from county agencies across the board, is that we're building programs, we're providing services, but we can't actually show how much of an impact it's having on the bottom line. And part of that is because of this fragmented data structure that we have, that we've built things in various places, and we've locked off elements of that data from each other. And so we can't go from an end-to-end data set to be able to say that, okay, this policy change resulted in the ability of a county organization using technology to do this actual workflow, and then the byproduct of that was what we met a need, and that need saved money back at the beginning. And we can't tie that all together because it's too fragmented. And so really what we're seeing in the private sector is, yes, we've got technology that allows us to bring that into a single platform. We refer to our system as a community care record. Like, we're approaching this from an EMR type approach, but on a community care record basis, so that the work that's being done is in the community. And the goal of it really is to be able to get the full outcome end-to-end data set in a singular space, so that we can bring that back to our partnerships that we have with the public sector, and actually help them to draw the correlation between the actions that they're taking and their policy changes and the outcomes that is happening on the street. A lot of it right now is theory-based. Like, I love the referral management platforms. We work with the big ones all the time, and we all know where they are. They're great, and they serve a purpose. But the reality is that the overwhelming majority of the work that's being done is in some community health worker's little black book. and she's sitting with someone in the emergency room or in a health center, and they have need A, and she's calling John at the local food bank and connecting this person to resources with people that she knows extremely well. And it isn't even going into that referral management system. The referral management system is being used for the stuff that she doesn't have an answer for in her little black book. But what's equally challenging in that is that that little black book isn't creating data. And so we still live in a data void on many, many levels, and right now we're trying to work with the public sector and private sectors, but a lot of our work is with county-based organizations or we're state-based organizations where we're trying to say, okay, let's connect the dots between the referral, the need was identified, the referral was made, actions were taken, the referral was met, and the outcome is this, and putting it all into a singular data set so that we can then go back and say, great, this is the outcome that we saw. This is how it can help you drive policy change. And equally as important, as I was saying before, is where are the needs not able to be met because we don't have resources available. That's a critical component to this that is still grossly lacking, especially in rural areas where we may have a food bank in every 3 to 4 towns, and then we end up with the inability to get people to the food bank because of transportation issues, and they all layer on each other and become a complex reality of trying to get these needs met. So that is a big piece of this. The last piece I just want to touch on real quickly is I think the public-private reality has been going on for a long time, right? We have most of the CBOs that are out there today they're being grant funded off of philanthropic resources or something else, and there isn't really public dollars that are driving them to do this work. They don't get paid for out of the public dollar, and yet the work that they do saves the public dollar. And so it's really fascinating to me that there's this disconnect between funding those very resources that are critical to meet the need and getting them to be able to increase their capacity and actually address the volume of need that does exist when the savings is actually having an impact on typically a Medicaid type system, and we're seeing that across the United States. So that's where I'm hoping that we're going to get to with some of the new funding that's out there now to the public sector, to be able to say, let's fund some of these programs in ways where they can actually meet the need, we can actually get that result. But again, in order to do that, we have to have outcomes data to be able to go back to the policymakers and say, this is what happens when you address these needs.
Right. No, that's just well stated, and you're sort of making me as a pivot to Dr. Lewis, and wanting to put the same question to him, but also want to sort of harken back to, his clinical training and anesthesiology and critical care, and there being an impact based on if we do this, then this will happen, and there being this causal relationship between an intervention that we put in place for a patient and what actually happens with their blood pressure, their respiratory rate, or whatever it is. As you talked a little bit earlier on about being more outcomes oriented and wanting to push in that direction, do you find it, I don't know, I know it's plausible, I know you agree with it, but how easy is it for you all to be able to engage in what we talk about as public-private partnerships from your perspective? And are they things that we need to look at and think about how to do differently to enable entities like yours to be able to do more of what they need to do or want to be able to do for patients to drive those outcomes that you were talking about?
Yeah, from the health plan perspective, in order to survive, we have to have connections with the stakeholders. So it's a public-private engagement all the way around. Otherwise, we're just not going to make it. So that's pretty easy for us. Is it easy to do? Yeah, it's pretty easy to do, but the limitation is time and focus and being on the same page with the other entities you're working with. So from a private standpoint, I'm saying private to private, working with some of the smaller organizations or some of what we call vendors out there is this great interest in driving improvements in certain areas, whether it's in opioid use or identifying behavioral health needs in different populations there. We don't have enough of the local internal team to keep working on that. Staff, we can only staff so many folks. So you have to bring in these partnerships there to try to improve in those areas. From a public-private standpoint, our products are government products. So we only survive because that's where our contract comes from. So, we speak to them, and we have to speak to what their needs are. And fortunately, the needs are based on some other agency recommendations about what's considered quality, what's considered a quality outcome. We have this data set called the HEDIS data set, in which insurance plans and managed care plans are measured upon. It doesn't necessarily correlate with the best outcome overall with everything, but it creates kind of a pace, a direction that you should be going towards. If you've got a certain behavioral health condition, if you've been put on medicine for a kid for attention deficit, do you have a follow-up in 30 days? If you've had hospital admission, do you follow up with a doctor afterwards? Are you taking a certain medication to improve your diabetes, a statin treatment? So we have these guidelines that are out there. It's the alignment with the public side of the world, and it is the partnership with our various vendors and private entities that allows us to drive towards improvements in care. So going back to kind of your question up front, social determinants is having a moment. Yes. The question is why? Well, we could all go around around the board here on what some of those things are. I'd like to add a couple things. One is dollars. We're up to 15% of our GDP being spent on healthcare. We just can't survive on that line item being spent on healthcare. So in addition to that, if you look at all the money that we spend in the U.S., if we've had some, maybe not the best outcomes data, Matthew, but we've had some outcome data in the sense that we have more advanced disease in the United States versus other well-to-do countries, right? We have greater suicide rates. We've got lower lifespans relative to other countries that are high financial earning countries. Why is that? And so that's the motivation to say that we can't sustain ourselves in the direction that we're going. We've got to do something about it. And so that is creating this urge and this hunger to create solutions. And thank goodness that there is awareness about equity and social determinants of health. Here comes the pandemic. COVID comes in. We're sitting around and we're saying, well, you know what? That's going on in China. That's not going to affect us. They've had some other things that come through. They've had some other SARS infections that come through, and we're going to be okay. Guess what? It comes in within a couple months and it takes over the US. We've got supply chains that's been affected across the world. We've got all kinds of issues. So we now have this realization that we are an integrated world. Funds only go so far, and we need to improve, and we can't isolate and say, well, it's only the frontline workers that are getting sick, so I'm going to be okay. We realize that we have to do something. So with that has created the motivation for these relationships and interactions between public and private side. And I think that it's just the right place, the right time to move towards advancing the health for a greater population instead of those who just have the means. And then we've got the technologies out there. This is, a discussion about the platforms. A lot of things I've been looking at, it's like predictive analytics and the predictive modeling. And, these are all big words and fancy words. It's about pulling data together, as the team has talked about, put them on platforms, and then we figure out how to use them. But we've got these tools out there. We put them in the right hand, the right people. We could advance the health of our population. Maybe it's a step at a time at a certain population at a time, certain groups. And when I say groups, I mean maybe condition groups, not necessarily background or origin groups, but we do a little bit at a time, and we take that and we transfer that over to other populations. So it's going to take a collaborative approach to get to where we need to go so that we don't run out of money.
No, I think that's well stated, and I think that it's as much as we've had these conversations before about the system costing a significant amount of our GDP and people not necessarily benefiting to the level that we feel that they should, given all of the resources that we have here. We do an amazing job in this country of providing excellent care at the beginning and the end of life, and in between, folks kind of get, I don't want to say lost, but they do to some extent get lost. And for different populations, that means different things. So we have these disparities that we've been talking about for a very long period of time, some of which have other completely non-medical backgrounds to them, but that sort of have social backgrounds to them, historical backgrounds to them that impact how and why care is provided in certain places to certain folks and not to other folks, or differently to one group than the other. Your comment just now, though, about the analytics is sort of what segues me to the next question, because we talk about predictive analytics, and it's something that, as our CEO Heather Flannery talked about before, we talked a bit about machine learning, we talked about leaving data in place to be able to do that, as opposed to having to share data, that being a concern with respect to, are you going to steal information from me, etc. Is there a way for us to have machines learn without data having to move? And there are federated learning models for that to be able to happen. But machine learning is a hungry beast, right? Machines need to get fed a bunch of different things in order to be able to predict something. I like to use the analogy of food because I love food. So if you were to say, if you were to only feed a machine burgers, and then all of a sudden throw some roti and curry at it, or throw some chicken tikka masala at it, it would sort of say, what is this? It'd have no context for what that other, quite delicious, by the way, meal option is, because all it knows is burgers. And so we have to do a different job with respect to how diversely sourced data is to get into those machines for the algorithms to do their learning and do what they have to do from there. So that sort of gets me to this next question, which is, you know, data comes from a number of sources necessary to paint the most accurate picture for us to be precise about the population health that we actually put in place. And so as we think about that little black book that Matt was referring to, I love that, the community health workers' little black book. As we think of that little black book and it having this treasure trove of data in it, how accessible is that little black book to the community-based organizations that those patients are served by, and also to the health systems that those patients are served by, that community health worker stands in the middle of, right? That community health worker is between those different systems. And how accessible is that social determinants data, and how are we going to be able to better draw on that information to inform care and inform the predictive analytics that Dr. Lewis was mentioning? I don't know, we can start getting into popcorn style here. I don't know who wants to jump on that first, but the community health worker little black book, how do we free the data from that little black book and get it to the right places so that predictive analytics can be more predictive for more people and more useful?
This is a really interesting conversation for me because we're coming at it from a little bit more simplistic approach, but I can see where the reality of what we're trying to create feeds into a bigger model, as you are all looking at right now. We recognize that we, as a software, we need to be able to bring a lot of people together so that we can do this in a singular space, so that we can create a database that's a single database that tells us the whole story from that end-to-end perspective, right? We're not in a place right now where we're saying, okay, what do we do with that data after we get there, other than to try to help the partnerships that we have with the public partnerships to drive policy change. But I think that my experience in bringing in data into our platform through various integrations, we bring in ADT data, we bring in HIE data, we bring in HMIS data for homeless systems. We a lot of different components of data into the system in order to help to drive the type of care that our caseworkers are actually working on. And all of that data is you're able to get it. It's a process by which to set up integrations with individual systems and exchange, the touch points and do the connectivity and pull the data in a regular cadence, and then make that data actionable, which is really the biggest piece of it from what we're trying to do is take this information data set, make it actionable within our system. And then from there, what's the next step? I think it would be amazing to take a system like, systems like ours and say, all right, feed it into a system where we can run machine learning. At a bare minimum, that data needs to get fed back into the healthcare system, because the healthcare system is going to change things that are happening in care delivery on their end based upon what we're doing. But we're not at that point of putting it into a machine learning stage yet. But I think it's a great concept.
I would say it's a tricky question. Dr. Vigilance, because the reality is we have these different organizations out there and they have some proprietary models and systems that are there. They're trying to build them, develop them, and not all models are the same. You know, we have a model that we use. It's called Impact Pro, that we use for identifying risk scores for our members based on the accumulation of information, whether it is your pharmacy utilization, your inpatient visit, the time of your inpatient visit, an ICD-10 code or diagnosis code that's provided. It's accumulation of all the data that they can collect. And it's still plenty of information that's not there, right? So you've got another product. You got that natural language processing, which because you have information that's on a piece of paper that doesn't come in. So the point is there's tons of information coming in. We're able to create that to create a risk profile. In addition, we actually work with an outside group that brings in social determinants based on the address or zip code that's put into the system. Create a risk score. We give this information to a care manager and say, hey, this is a high risk patient that we're going to need to do an outreach. We think that the condition is this, so please take the next step. The reality is that that care manager still has to do a little bit of processing because you know, you still have to improve the models. So you're improving your models, you've got this information, you're trying to have an impact. And what normally happens on the health plan side, and I'm not saying this is the way it should be, but this has been my experience, is that we do data sharing. So I'm getting to the ease of sharing. We do data sharing agreements with our vendors, with the providers, the physicians, the hospitals, and we essentially pull in information from them. And because of the demands, like on the provider group and the practice group, they do some analysis of the information, but we're looking for care gaps because we get more information coming in. So we're looking for those care gaps. Say you're just not getting your blood pressure medicine when you have a history of hypertension. We see that you're not refilling them. It's a delay in the number of prescriptions you had. We give that to them. It's a care gap. So the ability is there. The opportunity is there. It still needs to be developed, those relationships. There is a limitation because of the proprietary information that is out there and people trying to build. And we have to kind of create a means that people could advance with their abilities, their business, and the organization, yet still share the information so that it's not kept siloed because of the need of, you know, individual business gain. So it's a tricky dynamic, but that we're advancing. We've been forced to advance during this period of time. So that's my response to your question.
That's fair. That's fair. Josh, from your perspective, somewhat of a wax level maybe, but a different perspective. So what's your take?
Yeah, I think I mean, first off, what everyone's saying here is spot on. I come from I guess an orthogonal approach or perspective on things too, and hopefully interlockingly with what these gentlemen are talking about too. We have clinical systems, if I can reduce it to that are trying to track social problems, and as I've repeatedly keep saying here, and please let me know if it's too much, we have community level problems that need holistic redressing or addressing from outside of the healthcare system. I think it actually burdens the healthcare system a bit too much by saying doctors, nurse practitioners, and you know, clinical systems. Now, in addition to trying to still figure out interoperability from standards we started putting in place, you know, 10 years ago, now also start tracking all this other data and make it really, really useful and meaningful and fix all these problems. I think it's actually kind of it's too difficult of a problem to solve. And this is where it goes back to your public-private partnership thing and other pieces pretty meaningfully. So data is the critical underlying factor that we need to really meaningfully address to solve social determinants. We can't study what we don't know, and we have so much more to unlock, I think, in terms of data between sectors. What Dr. Lewis was referencing before and what Matt said before too, I think are care gaps, but there are community gaps that I think still exist too, outside of what it might be most directly relevant to clinical care right now. And so I think from our perspective here, and many others hopefully would agree, we have more data to collect and harmonize that still just doesn't exist. They don't exist in our and our open data sets that the federal government puts out there, if they're not something that a clinical entity is tracking, there's still a lot of gaps to try and fill there. And so I think that's part of it. And certainly there are existing systems that just aren't part of it yet. So how do we integrate what's already out there? How do we adapt what's already out there? But then also, I think we need to acknowledge that there is a gap in other types of data that need to be pulled, need to be collected and addressed. That's one piece. Harmonization of that data is I think the next piece. Just because we have a bunch of data doesn't mean we're going to be able to do anything with it. And so tracking and collecting data and then putting it into meaningful, and I'll use the distinction of health improvement versus healthcare improvement, I think is really critical too. Healthcare improvement, absolutely necessary. And we have ONC and ARC and other parts of HHS that are trying to develop clinical standards for social determinants and other interoperable pieces there. But I think we also need to think about how all this other data is holistically improving the way communities, cities, towns, states, tribes, territories are all improving as well too. And we haven't really cracked that nut just yet, but I think we're working on it. There are some initiatives I can we speak of sort of generally that are looking into federal data sharing. How do we start leading the way by making sure that our data at HHS, one is we have the data use agreements to talk to HUD and transportation and USDA and other folks to even do our research, but two, in a more activated sense, how can we then open that up for real use in the world? And so you started this conversation with analytics and that piece, and I think that's where it all comes together. If we actually start collecting all this data, both at the clinical level and at the community level, and turn it into something actionable, and maybe that's something that HHS can be leading at some point in the future. We have an Office of the Chief Data Officer now, which is a relatively new team here, but it focuses, I think, on the bigger picture perspectives of what health can be and not our health data can be outside of just sort of the clinical standards. So part of what we do there is to hopefully lead to dramatic change that will unlock this bigger picture interoperability conversation. Ultimately, I'm a big believer in community health as a really important metric that we're not really focused on yet. So how do we actually improve not just individual or population metrics that are reducing costs, but also at that community zip census level, making big dramatic changes there too, because all of it has to work towards something. And that's where I think we can help set standards to do that, or targets, if you will.
Yeah, I think that having an understanding of what does it mean to be doing it? So your point about, and I appreciate this analogy, sort of collecting more data, that's part of it. Harmonizing the data, so that's basically more instruments into the building. Fine, you've got more instruments in the building. Now, what are they playing? And it doesn't make any sense if I'm playing Rachmaninoff, you're playing Bach, someone else is playing Mozart at the same time. That's a cacophony. It's a lot of great music, but it sounds horrible together. We've got to be playing it together. And then how am I listening to it, right? Am I listening to it live in the room? Am I listening to it over a headset? Am I listening to, what is that experience like? And then what do I use that for, right? And I think that may be, it may be slightly different for different parts of this equation. But I think that what you're making me think about, though, which is a question that I want to ask all of you, and we're coming to our last 10 minutes, is the data, more data will sound to some communities like, more questions. Here come a whole lot more questions being asked. And when I say that, and I say that with that resignation, because there are so many communities, particularly underserved communities, that have been involved in the study of the study of the study, where the questions have been asked over and over again from different angles, not necessarily by entities like any of yours, but maybe by academic entities that have a particular question that they're trying to respond to an RFP in, and coming back again and now saying, oh, and by the way, we want more. So which is why I think some of this conversation about, if I'm going to be providing you with this data, with these responses, then should I not be getting something for it that I don't have to necessarily wait for way down the street, which is, well, we're going to be trying to improve your health outcomes. Yeah, that's going to happen at some point, but what about right now? So yeah, this is just a question that's sort of coming to my head as I'm listening to you all talk about this. Yes, more data is necessary. Yes, we need to harmonize it. We have to get more of it in first. What do you think are some of the ways that we might be able to get more and better data in to be able to do some of the things that we're talking about? Are you working at all in any of your settings on ways to get more in so that we can do more with?
Yeah, I mean, I'll start with a quick analogy to give others a little time to think about their answers, because I think someone else referenced this too, from their, maybe it was Dr. Lewis from his clinical perspective, but when I ran the community health center I mentioned before, it was actually an addiction center, and one of the biggest problems we had was therapist turnover. And I remember one patient, when one of our therapists left, they were really distraught about having to retell their story to a new therapist. It was to the point that they wanted to quit mental health altogether, and it was addiction centers. They wanted to focus on just the addiction piece. And we really urged, apologized and said, you gotta stick with it as much as you can. And I'm sorry about this, but I think similarly, this past summer we did some research, some human-centered design research, where we actually talked to communities across the country, focused actually at the crosswalk of climate change and health equity and social determinants. And so we're talking to climate-affected areas. And one of the most common responses we got in that HCD process was, hey, we're here in Puerto Rico. We get hit by a hurricane every year, multiple times a year, and someone always comes and asks us a bunch of questions, and nothing ever changes. And same thing everywhere else that we've talked to too. And so I think, interestingly, your point is well taken, that we need to do better at thinking about how we're outreaching and getting data too, and not disrespecting communities, but also if we are going to come in and talk to people and try and do something, make it actually happen, have follow-up actually occur too. I think that's one thing that we're trying to engender here in this innovation team, is building a pipeline to communities that will hopefully be the pipeline for communities, between the feds and communities, and maybe in that process actually be able to build trust, because they can hear from us more directly. And so I don't know what that pipeline looks like. I don't know what technology, if that's technology, if that's just us picking up the phone more, but either way, being methodical in the way we think about it is a form of or a way that I think we can respond to your question, which is understanding and empathetically thinking about how these communities are dealing with things, or people are dealing with things too. But other thoughts?
Well, I can tell you a little bit. One of the things you said that really stuck out to me was talking about one of the things I love about working in social determinant space is that, when we look at healthcare, so many things in healthcare, and we've all experienced these, are long-term in nature, right? You're treating someone's diabetes over the course of years of their life, and or their cancer treatment, but in social determinants, so often we have the rare opportunity to address something in the moment that changes people's lives in the moment, and it's a very powerful thing. And when we can do that, it means something to the individual. But the worst case scenario is when we ask them the question and then we don't meet the need. That's what we have to try to avoid. And so, I think that is foundational to everything that the groups that we work with are trying to make sure that when we're doing that screen, we're doing a full prepare screen with someone, that when it's done, we're actually getting them in contact and helping them meet the needs that are addressed, and not just sending a referral out through a system, but actually walking them through the process. And so I think that's a really important piece to this. But when it comes to the data components to this, we're actively working with a couple of states right now to walk them through a process by which we want to help them to really do a full gap analysis of need based upon resources, based upon resource capacity, because they're really three different things, right? And so we're proposing with them to do a widespread screening process with large populations to really learn where their needs are and how the needs break down by geographic region, urban versus rural, and then take that information and drive it into what resources are available in those communities, and deeper, what's the capacity, so we can really understand where our gaps are. And in this instance, the gap is we have, again, 1,000 people that have food insecurity in an area where we can only manage 500 of them on a monthly basis. And so we can't ever meet that need until we close the gap in how the CBOs are able to give out food. That's a big part of this. But the other piece to it is that technology is an amazing thing. We live in a great time in our country, and there's a lot of different ways to move information around. And one of the things that our team feels strongly is that when if we look at the top 10 needs around the United States, they're almost always consistent, right, across the board. We have the same top 10. The order changes a little bit, but the actual needs don't typically change a lot. But the question is, which of those needs can be addressed through some kind of a technological or educational resource tool versus which of those needs need to have a high touch RAP model where a CHW is walking them through the process. And that is probably going to be different based upon the geographic region that the individual lives in within an individual state. And so we're saying to the states, we want to build a best practice model that's specific to your area, your geographic realities, and it's going to be different in one part of your state than it's going to be in another part of the state. But once we fully understand that, we have the gaps, we have the data to show that these are the needs, we have the data to show where the needs are more prevalent and which ones need a RAP versus which one needs education, then we can go back to that all important point on this, which is policy change, right? To get the policies where they need to be in order to fill the gaps and allow these type of best practice models to actually have the biggest impact.
Very good. Okay, thank you. Thank you. Dr. Lewis?
Hi, both of you have hit on some points that sparks an idea for me. First of all, I would say that there's a lot of information that we're not capturing, and that's why I mentioned the tools of the natural language processing. There's lots of clinical information to the record that is just not making it to the data platforms that would yield a lot of information that would help with social determinants. So that's there. On the other, in addition, in getting more information, I don't see this as an opportunity where you just sit and do a survey and pull information. I see it from a certain viewpoint, the viewpoint in which one I try to practice. I'm not coming to you as the sole source of knowledge and information. You're going to feed me and I'm going to tell you what to do. I'm going to go from there. I see us on an even setting. You're giving me something, I'm going to help you. You don't know how you're helping me, but in that process, Matt mentioned power, and there's power and self-empowerment when people realize that you're working together for a benefit. It could be their benefit, and obviously they're thinking of themselves, they're thinking of someone like them. That's why so many people work with these advocacy groups. So there's an empowerment that you have in having that conversation when you're eye to eye in that conversation, not this superior, all knowledgeable one that's sitting up there. So that's the perspective that I see where it is helpful and easier to get the information. And then Josh hit on the big point, and that is trust. If I trust that you're coming to talk with me to assist me and you're genuinely going to work on it and you're interested and you're not trying to fulfill some kind of personal need, it just flows naturally. So that's the perspective that I see in getting additional information, but I do see that there's plenty of information out there to help guide us in some of our decision making.
Yeah, no. Those are, and I appreciate that each of you are able to pull from, and you've not met before, at least not to my knowledge, you're able to pull from each other's comments, even though you're coming from slightly different spaces, but you're all heading in the same direction, maybe in slightly different vehicles, but heading in the same direction and wanting the same things for the communities that we serve. And those points that you just made, Dr. Lewis, with respect to partnering with somebody and like, as we like to say in human-centered design, designing solutions with rather than for people is a key element to the trust building piece that goes on. But it's also and this sort of speaks to this other element. We talk about COVID a lot with respect to what's impacted our last couple of years, but also this country has gone through this sort of racial related reckoning conversation that we've been having that has highlighted a number of different things related to diversity and inclusion and equity itself. And the notion of power and how power is shared or not is something that comes up in community conversations that might be captured in a dialogue way or in a text-based way that an actual language processing tool may be able to be put to use in, but that won't necessarily be captured in a medical record or in a health record, because that's not the context in which that conversation happens. And so where and how we're collecting data is going to impact that different data that we collect. And I think that needs to be informed to some extent by what Matt was referring to as the gaps in data, identifying what those gaps are, and then creatively filling those gaps with this trusted partnership type of connectivity that we can have. We are at time. So many gems from this conversation, and I appreciate all of them. Loved again the Community Health Worker Little Black Book, how we go about doing this predictive analytics, and whether or not we're going to be able to get the right kind of data from people and understanding what that means. The harmonizing of that data is extremely important, and how we build trust through partnerships, be they public, private, or really just person to person. And the other thing that often gets lost in tech-related conversations is tech doesn't solve anything by itself. We need people to be engaged in that process, be they as users or designers or developers or whatever it is, or intermediaries like community health workers. And we need for that to be the case going forward. So I'm at time. Thank you again, Dr. Barry Lewis from Centene, Matthew Goodrow from Activate Care, and Joshua Prasad from HHS. Thank you very much for your time this afternoon and in leading up to this conference as well. The preparation for this, outstanding working with all of you. I wish we had more time for our conversation, but unfortunately we don't.
Thank you all very, very much. Matthew, Joshua, Dr. Lewis, and of course you, Dr. Vigilance. That was an excellent conversation, an outstanding way to end a great day. And thank you to all of our panelists and attendees today. And I think, not just the social determinants of health aspect that ties back in both to the veteran population we focused on today, but to every population, and especially those that have been underserved. But I think the element there at the end, the human-centered design, and thinking about it in what John Boyd used to say, people, ideas, things in that order. You don't start with the tech, you start with the people, you start with the problems, and then you move to the ideas and the solutions, and then you figure out ways that tech can augment those solutions, not become the solution. And that, I think, is really where we're heading. So with that, I'd like to close and say thank you all, and a lot of great discussion, a lot more discussion and activity to come on this subject, and we look forward to continuing the dialogue. Thank you.